Good afternoon, everyone, guys. I'm audible and visible to all of you. Please update me in the chat box. Update me in the chat box. Good afternoon to everyone. So, welcome to the session. Today we are going to have a part 1 of Obstetrics and Gynaecology Rapid Revision. We'll try to cover all the important topics, all the recent PYQs that have been asked in your exams, and we'll have a concise session of 3 hours almost, and then followed by that tomorrow we are going to solve part 2 of OB-GYN. Okay, so I'm expecting that you guys will be interactive during the session, answer all the questions, answer everything whatever you guys know about the related topic. Okay, yes. So let's begin, guys. Without any further delay, let's start with our first chapter, with our first topic of the day. That's going to be ectopic pregnancy. Most important topic from obstetric point of view. They have been asking multiple questions on this topic, and I always say focus on the management part more. Focus on the management part more. Okay, we'll be solving questions as well during the session. So let's discuss in a very concise manner this particular topic, ectopic pregnancy. Now if we try to define this ectopic pregnancy, what is ectopic pregnancy? It simply means the pregnancy outside the uterus. So it simply means the pregnancy outside the uterus. This is the normal pregnancy, okay, intrauterine pregnancy, and any pregnancy other than the uterus, any pregnancy outside the uterus, that's going to be the ectopic pregnancy. And the most common location of this ectopic pregnancy, the most common site of this ectopic pregnancy is going to be fallopian tube. The most common site is going to be fallopian tube, and the most common site in fallopian tube, if the question will be asked, your answer is going to be the most common site in the fallopian tube, your answer going to be the ampulla. Okay, so simple means, what is ectopic pregnancy? It means, sir, it simply means pregnancy outside the uterus. It simply means the pregnancy outside the uterus. Okay, and if we talk about the most common site in fallopian, most common site, that's going to be ampulla. Okay, now this ampulla, followed by that, what is going to be the most common site? Sir, isthmus. Followed by isthmus, it's going to be infundibulum. Followed by that, it's going to be interstitium. Followed by that, it's going to be interstitium. Is that clear? So most common site is going to be fallopian tube. Most common site in fallopian tube is going to be ampulla. That's going to be ampulla. Now my question to you, the PYQ was asked that ampulla is also most common site for two conditions about the ampulla. Tell me, it's also most common site for, it's a site for fertilization, number one, and it's the most common site for genital tuberculosis. So write it down here. Two questions that have been asked in your exams. So this ampulla, it's going to be most common site for genital tuberculosis. Okay, and it's also the site for fertilization. It's also the site for fertilization, more precisely ampullary isthmus junction. Okay, is that clear to everyone? And one more thing about the ampulla, you will remember, guys, it's also the widest part. It's also the widest part of the fallopian tube. It's also the widest part of the fallopian tube. If the question will be asked, which of the following is the narrowest part of the fallopian tube, your answer goes to, update me in the comment section, your answer goes to interstitium. So interstitium is going to be the narrowest part of a fallopian tube. Okay, now if we talk about the most common cause, there are multiple causes for the ectopic pregnancy. Now the most common cause is going to be pelvic inflammatory disease. So what is the most common cause of this? So most common cause of ectopic pregnancy is pelvic inflammatory disease. We also call it as salpingitis ischemic nodosa. क्या बोलते हैं बच्चे? Salpingitis ischemic nodosa. Okay. Now, what can be the other causes of this ectopic pregnancy? So, any pelvic surgeries, any tubal surgeries, patient using the intrauterine contraceptive devices, patient having endometriosis, patient having genital tuberculosis. These are all the other causes for the ectopic pregnancy. Okay. Now, if we talk about most common risk factor, if they ask most common risk factor, that's going to be previous ectopic pregnancy. That's going to be previous ectopic pregnancy. Clear to everyone? That's going to be previous ectopic pregnancy. Now, the most important point in this particular topic is the presentation of the patient. As we all know, all the questions from an OB-GYN, there will be a common presentation. Patient is complaining of pain abdomen, and along with that, patient is complaining of bleeding. Patient is complaining of pain abdomen and bleeding. Now, if we talk about the classical presentation of an ectopic pregnancy, there are three things. Patient will first complaining of amenorrhea. So patient will be amenorrhea, and this ectopic pregnancy case will come around 6 to 10 weeks. Usually कब आता है? So it usually comes around 6 to 10 weeks. Patient will have amenorrhea. Patient will have pain in abdomen. Patient will complain of pain in abdomen, and patient will complain of bleeding per vaginal. Okay, now bleeding per vaginal. Okay, the classical triad of symptoms: amenorrhea, pain in abdomen, bleeding per vaginal. Now, depending upon the site of an ectopic pregnancy, if my question will be, what is the earliest part of an fallopian tube to rupture in case of an ectopic pregnancy? What will be your answer? Write down the answer in comment section. What will be the earliest part to rupture in case of an ectopic pregnancy? So, the earliest to rupture is? Sir, the earliest to rupture is? Yes, anyone in the comment section? Earliest to rupture is around 4 to 6 weeks. That's going to be? Yes, isthmus. Earliest to rupture is isthmus. Very good, sir. Earliest to rupture is isthmus, and this is around 4 to 6 weeks. Okay, you just take a middle one, that's around 6 weeks. Earliest to rupture is 6 weeks. If we talk about ampullary ectopic in the ampulla, that's going to be around 6 to 8 weeks. Followed by that, corneal ectopic, 12 to 16 weeks. Okay. Now, next earliest to rupture is isthmus. Now, depending upon an ectopic pregnancy, now if the ectopic pregnancy is in the fallopian tube, now either there can be two scenarios. What can be the two scenarios? So, या तो ये ectopic ruptured होगा, या तो ये unruptured होगा. Now, two things will be there. Either it's a ruptured ectopic pregnancy, or either it's an unruptured ectopic pregnancy. Now, if I define the ruptured ectopic pregnancy, eventually when the rupture of tubes will be there, rupture of a tube will be there, patient will have a lot of bleeding. When a patient will have a lot of bleeding, patient is having excessive bleeding, what will happen to the vitals? Patient will have a decrease in the blood pressure, followed by that, due to the hypovolemia, cardiac output will be decreased. Due to the decrease in the cardiac output, there is decreased cerebral transfusion. Eventually what will happen? Patient is having a syncopal attacks. Okay, so remember one important point: whenever the vitals are unstable, you are thinking about ruptured ectopic pregnancy. So either, sir, two scenarios can be there. Sir, या तो ruptured ectopic pregnancy होगा, or there will be unruptured ectopic pregnancy. In ruptured ectopic pregnancy, sir, vitals are not stable. First thing, so vital or not stable. Okay. Number second thing is going to be, due to the increased blood loss, due to the hypovolemia, okay, there is a irritation of a diaphragmatic part due to the hemiperitoneum, and that irritation causes the referred pain in the shoulder. Can anyone tell me what is the name of the sign? Okay, we have shoulder tip pain. And this shoulder tip pain is a referred pain, and this pain is due to the hemoperitoneum. जो blood accumulate हुआ है, जो blood वहाँ पे है, that pain is due to the hemiperitoneum, or it is due to the diaphragmatic irritation. What is the classical sign called as? Anyone in the comment section? What is the classical sign called as? So that is called as Danforth sign. क्या बोलते हो sign को बच्चे? So that is called as Danforth sign. And this shoulder tip pain, it's a referred pain. It's a referred pain due to the hypovolemia, due to the hemiperitoneum, the blood that is accumulated over there. Along with that, it is due to the diaphragmatic irritation. Very good. Now, I've already told you that due to the hypovolemia, cardiac output is decreased, okay, due to which the blood pressure is decreased, due to which cerebral perfusion is decreased. That's why a patient is having a transient attacks. That's why a patient will also complain of syncope. So syncope and shoulder tip pain, these are the classical features of which type of ectopic pregnancy? So they are the classical features of a ruptured ectopic pregnancy. ectopic pregnancy. Now, due to the hemoperitoneum, when the blood loss in the ruptured ectopic pregnancy, there is a hemorrhagic discoloration of the umbilical area. This hemorrhagic discoloration of an umbilical area is called as Cullen sign. क्या बोलेंगे इस sign को बच्चे? Sir, this is called as Cullen sign. So what is Cullen sign? It's bruising around the umbilicus. It is called as Cullen sign. It's called as Cullen sign. Okay, and bruising around the flanks, it's called as Gray-Turner sign. So it's called as Gray-Turner sign. So Cullen sign and Gray-Turner sign are the classical signs seen in which condition? So they are seen in ectopic pregnancy. Besides ectopic pregnancy, bache, these signs are also seen in acute pancreatitis. But acute pancreatitis, we have other signs as well. Like we have bruising around the inguinal region, bruising around the scrotal region. Okay, like we have Bryant sign, we have Fox sign. These are the other signs seen in pancreatitis. So in ectopic pregnancy, there is a hemorrhagic discoloration of the skin around the umbilical area and around the flanks, called as Cullen sign and Gray-Turner sign. Number one thing. Number second thing is, sir, if the vitals are unstable, patient is having shock-like features, patient is having a syncopal attack, patient is having a Danforth sign, that is a shoulder tip sign. These are the indications of which type of ectopic pregnancy. They are classically what? Features of ruptured ectopic pregnancy. Okay. Now, if a patient is coming with a ruptured ectopic pregnancy, what is the first thing we will do? Yes. What is the first thing we will do? So first of all, we will do resuscitation. First of all, we are going to do resuscitation. Okay. First thing, resuscitation. Okay. Followed by resuscitation. Yes, sir. Guys, secure the IV line. Okay. Secure the IV line. Secure the IV line. Followed by that, arrange the blood. So we'll arrange the blood, and the only surgery that we will do is going to be total salpingectomy. That's going to be total salpingectomy. Remember that the surgery is going to be total salpingectomy. Sir, there should be no role of beta HCG. There is no role of ectopic mass size. The only treatment in case of a ruptured ectopic pregnancy is going to be salpingectomy. Now this salpingectomy is of two types. So either I can do through via laparoscopic salpingectomy or laparotomy. Laparoscopic salpingectomy or laparotomy salpingectomy. Remember, my dear students, whenever a patient is having vitals stable, if vitals stable, we can go for laparoscopic as well as laparotomy. Okay. If vitals unstable, that means if a patient is in the shock, remember laparoscopic is contraindicated, because further when you inflate with the carbon dioxide CO2 gas for the laparoscopic procedures, it will decrease the cardiac output. Patient is already having a hypotension, it will further do more hypotension and eventually the symptom will worse. So always remember, we'll go for laparoscopic salpingectomy in case only when the vitals are stable. If the vitals are unstable, your answer is going to be laparotomy salpingectomy. Your answer is going to be laparotomy salpingectomy. Is that clear? Is that clear to everyone? Is that clear to everyone? Yes. On per abdominal examination, you eventually know, sir, what will happen. Patient will have an abdominal tenderness and there will be rebound tenderness. On per abdominal examination, there will be abdominal tenderness. There will be abdominal tenderness. There will be abdominal tenderness. Is that clear? Is that clear to everyone? Now, depending upon an unruptured ectopic pregnancy, in unruptured ectopic pregnancy, we have to save the tube. Okay, try to save the tube. So depending upon the size of an ectopic mass size, depending upon the beta HCG levels, we have two things. So either we can go for the medical management or either we can go for the surgical management. Now, what are the medical management drugs? Write down in the comment section. What are the medical management drugs in an ectopic pregnancy, unruptured ectopic pregnancy? So we can go with the most important drug, methotrexate. या तो methotrexate देंगे, number first thing. Number second thing is we can give mifepristone, antiprogestin. Third one, we can give prostaglandins. And fourth one, we can give KCL We also give actinomycin. Is that clear? These are all the drugs in an unruptured ectopic pregnancy. They are all the drugs given in unruptured ectopic pregnancy. Is that clear? Is that clear to everyone? Yes. Chalo. Now, what are the surgeries that we do for an unruptured ectopic pregnancy? Number one is going to be, so we can go for salpingotomy. So we can go for salpingotomy. Number second, so we can go for salpingostomy, depending upon whether we take the, after taking out an ectopic we suture or not. We have two things, salpingostomy. We have milking of tube. It's an outdated procedure, milking of tube, or resection anastomosis, This is all about the medical management and surgical management. It's all about the medical management and surgical management for unruptured ectopic pregnancy. Now, what are the criteria that will follow on choosing a medical management and a surgical management? Now, if a patient is coming to you with an unruptured ectopic pregnancy, so either I will go with the medical management. So either I am going for a medical management. So either I'm going for surgical management. So either medical management or surgical management. And we have important factors. Okay. Now, my dear students, if a beta HCG levels, number first thing is, sir, if beta HCG levels are less than 5,000 international units, I am going with a medical management. Okay. So if beta HCG levels are more than 5,000 international units, I'm going with the surgical management. If beta HCG is if beta HCG is less than 5,000 international unit, I'm going with the medical management. If beta HCG is more than 5,000 international unit, I'm going with the surgical management. Number one thing. Number second is going to be size of ectopic. Number second thing is going to be size of ectopic. Okay, if the size of the ectopic is less than 4 centimeters, you have to choose a medical management. If it is more than 4 centimeters, you have to choose the surgical management. Okay, if we talk about hemodynamics, if a patient is stable, you go for the medical management. If patient is unstable, you go for a surgical management. Is that clear to everyone? So main two, we have also, my dear students, we have also signs of rupture. You already know, if the signs of rupture are present, you are going with the surgical management. If the signs of rupture are absent, we are going with the medical management. So eventually, when the signs of rupture will be present, patient is hemodynamically unstable, that's what states. The unstable patient go for the surgical management, unstable patient you go with the medical management. Clear to everyone? Is this much clear to everyone? Now, in NEET PG, the question was asked, there are different criteria for an ectopic. Okay, now this ectopic pregnancy, rather than the fallopian tube, it can be in the cervix, it can be in the abdomen, it can be in the previous cesarean scar. So we have a different types of an ectopic pregnancies and the criteria. Now, my first question to you guys, so if there is a cervical ectopic, what will be the criteria? If a patient is having a cervical ectopic, what will be the criteria for the cervical ectopic? So the name of the criteria is, it starts with R, it's a Rubin's criteria. What's the name of the criteria? So it's going to be Rubin's criteria. So if the patient is having ovarian ectopic, this is a NEET PG recall question 2022. So if a patient is having ovarian ectopic, it goes with the Spiegelberg's criteria. Okay, this was the question asked. Okay, and if a patient is having abdominal ectopic, pregnancy, the abdominal ectopic pregnancy, the treatment will be, the name of the criteria will be study Ford criteria. Study Ford criteria. It will be study Ford criteria. The number fourth one will be if a patient is having cesarean scar ectopic pregnancy. If a patient is having a cesarean scar ectopic, the cesarean scar ectopic will be having a criteria called as Gordon's criteria. So it will be Gordon's criteria. That's all. So remember we have cervical ectopic, remember we have ovarian ectopic, we have abdominal ectopic, and we have cesarean scar ectopic. We have cesarean scar ectopic. These are the named criteria. Okay, now if we talk about the investigation of choice in ectopic pregnancy, anyone in the comment section, what is an investigation of choice in ectopic pregnancy? So the answer goes to transvaginal scan. So the answer goes to transvaginal scan. Okay, next, if they ask gold standard, the answer goes with laparoscopy. The answer goes with laparoscopy. The answer goes with laparoscopy. Okay, now remember guys, we also check the beta hCG levels prior to that. If the investigations, if the USG is inconclusive, I'm repeating, if a question mentions USG is inconclusive, what will be your treatment? What will be your treatment? So treatment, first we have to diagnose whether the pregnancy is inside the tube or inside the uterus. So you're going to do beta hCG levels. Now beta hCG levels, three scenarios. If it is doubling after 48 hours, if it is doubling after 48 hours, it's going to be intrauterine pregnancy. If it is doubling in 5 to 7 days, okay, it's going to be ectopic pregnancy. And if there is a fall of more than 50%, it's going to be the case of abortion. That is coming up. Remember three scenarios. So if the beta hCG is increased and it's doubling in 48 hours, it's going to be intrauterine pregnancy. If beta hCG is doubling in 5 to 7 days, or it's just 30% double after 48 hours, it's going to be the ectopic pregnancy. And if there is a fall in the beta hCG levels by 50%, this is a classical case of abortion. This is a classical case of abortion. Okay, and you also remember what can be the differential diagnosis of this ectopic pregnancy? It can be appendicitis or abortion. Okay, appendicitis or abortion can be the differential diagnosis. Is that clear? Is that clear to everyone? Yes? Chalo. Now if one question will be asked based upon this ectopic pregnancy case, answer me this particular question. A 25-year-old, a primary gravida. So we have a primary gravida, a lady who is pregnant for the first time. She's presenting with you with the complaints of a lower abdominal pain and the bleeding per vaginum. So classical two symptoms, sir, bleeding and lower abdominal pain. On palpitations, the tenderness is noted and bruising is seen around the umbilicus. So bruising around the umbilicus, the hemorrhagic discoloration of the skin, it's classically Cullen sign due to the hemoperitoneum. So you are thinking that bleeding is more inside. That's why we are having this Cullen sign. The further examination reveals the blood pressure of the patient is 90/60. So patient is having hypotension. Blood pressure is 90/60 and the heart rate is 110 beats per minute. The UPT was positive and the beta hCG was 1500 international units. USG performed, there is no double decidual sign. Now in the chapter of diagnosis of pregnancy, you know that if there is a double decidual sign, parietalis capsularis, we have a classical double decidual sign, it indicates the intrauterine pregnancy. And when there is no double decidual sign, so kya hai? That means it's in case of an ectopic pregnancy. The adnexal mass was noted. What will be the most appropriate next step in the management? So what will be your management in a patient having a case of an ectopic pregnancy? So you have to classify whether it's a case of a ruptured ectopic pregnancy or it's a case of an unruptured ectopic pregnancy. So look out and let me know the answer. Should we go for the laparoscopic linear salpingostomy? Should we admit or immediate termination? Should we do laparotomy, total salpingectomy, or you can give single dose methotrexate? Write down in the comment section what can be the answer, bache. What can be the answer? So you have a patient with an ectopic pregnancy case. What will be the answer for this particular question? Yes. What will be the answer for this particular question? Very good. Answer is going to be C. Answer is going to be C. So laparotomy, total salpingectomy. I've already discussed that. The vitals are unstable. You cannot go for the laparoscopic salpingectomy. The answer is going to be laparotomy plus total salpingectomy. You might are thinking that the beta HCG levels are less than 5000, sir, but there is no role of beta HCG levels in case of a ruptured ectopic pregnancy. There is no role of an ectopic mass size in case of a ruptured ectopic pregnancy. The only one answer is going to be, and that answer is total salpingectomy. Make sure if vitals are unstable, it's a case of a ruptured ectopic pregnancy, and you cannot go for a laparoscopy. Okay, next question. A patient taken up for the normal vaginal delivery who was in the labor. So patient is in the labor going for the normal vaginal delivery. The child had a vertex presentation. Okay, the child had a vertex presentation. So we have a different types of a presentation. What does the presentation mean, sir? So presentation means which part of the fetus is lying on the lower pole, which part of the fetus is touching the lower pole. If a head is touching, I call it as a cephalic presentation. If a shoulder is touching, I call it as a transverse presentation. Or if the breech is touching, I call it as a breech presentation. Right? Now, depending upon the flexion and the extension of the head, this cephalic can be of different types. It can be of face presentation, it can be of brow presentation, or it can be of vertex presentation. That's what I call it here, what I have written, vertex. So vertex is a type of a cephalic presentation in which in the lower pole head is touching. Is that clear? The position is occipito-posterior. Occipit on the posterior side. Sir, what is occipito-anterior and what is occipito-posterior? Occipit on the posterior side, I call it as head, occipito-posterior. Occipit on the anterior side, I call it as an occipito-anterior. Okay, the head rotated partially. Okay, the head rotated partially and it went into deep transverse arrest. The head got stuck in between and this arrest is called as deep transverse arrest. Which of the following pelvis can lead to this condition? Now, depending upon the type of pelvis, we have 4 types of pelvis, we already know. So we have gynecoid pelvis, we have anthropoid pelvis, we have android pelvis, and we have platyploid pelvis, Okay, now my dear students, the question is that which type of pelvis will have deep transverse arrest? Okay, now remember, either we have occipito-posterior and occipito-anterior. Now remember, 80% of occipito-posterior will change into occipito-anterior and they will be delivered with a normal vaginal delivery. So can I say that when there is a rotation from the occipito-posterior to the occipito-anterior से occipito-anterior जब rotate हो रहा है, that means the type of a pelvis is a very nice pelvis. Why? Because it's a rounded cavity. There is no obstruction, there is no arrest, there is nothing. Simply from occipito-posterior it rotates to occipito-anterior. Such type of pelvis is the most common type of pelvis called as gynecoid pelvis because it's a rounded cavity. So 15% of occipito-posterior, they will remain occipito-posterior only. Now why they are not changing? Because the type of the pelvis. So that means the type of the pelvis is not rounded. It is an oval shaped pelvis called as anthropoid pelvis. And 2 to 3% they get occipito-posterior, they get stuck, which is called as deep transverse arrest. So my dear students, we have 3 scenarios. So occipito-posterior to occipito-anterior, then occipito-posterior remaining occipito-posterior only, and 2 to 3% they try to rotate and in between they got the stuck, which is called as deep transverse arrest. Now very simple question, you have to remember only few things. If you remember deep transverse arrest, you should know that means the type of the pelvis in this deep transverse arrest, it's a triangle shaped, it's a heart shaped pelvis, and the heart shaped pelvis or the triangle shaped pelvis is an android pelvis. The type of the pelvis is going to be android pelvis. So we'll study what are the different types of pelvis, which of the following pelvis has a which type of presentation. So I will give one keyword for the questions. You have to remember rounded cavity, transverse, oval, heart shaped, and transversely oval shaped pelvis. Okay, so all these 4 things you will remember about each of the following pelvis and which of the following presentation will be associated with each of the following pelvis. What is presentation? So the part which is touching the lower segment. Is that clear to everyone? Any doubt, any single thing, you guys can write down in the comment sections, okay, related to the particular topic. And one question is confirmed from such type of pelvises, okay, but all you have to remember is डीप ट्रांसवर्स अरेस्ट कहाँ पे दिख रहा है, ऑसिपिटो पोस्टीरियर प्रेजेंटेशन कहाँ पे मिलता है, ऑसिपिटो एंटीरियर प्रेजेंटेशन कहाँ पे मिलता है, फेस प्रेजेंटेशन कहाँ पे मिलता है, व्हाट इज द मोड ऑफ द डिलीवरी, फेस टू प्यूबिस कहाँ पे करेंगे. सो ऑल दीज थिंग्स आर द कीवर्ड्स व्हेन यू सॉल्व द क्वेश्चंस फ्रॉम द टाइप्स ऑफ pelvis. Okay, now if we talk about the first type of pelvis, that's going to be gynecoid pelvis. The first type of pelvis, it's going to be gynecoid pelvis. So this gynecoid pelvis, it's a most common type having a rounded cavity. Having a which type of cavity? Rounded cavity. So first thing about this type of pelvis, you will write it's the most common type of pelvis. It's the most common type of pelvis. Second thing, sir, it has a rounded cavity. So it has a rounded cavity. As I've already told, one more important point, that of 80% of occipito posterior, 80% of occipito posterior, occipit on the posterior side, they will convert to occipito anterior, and that means the cavity that we have is a rounded cavity. Is the cavity we have is a rounded cavity, and such type of pelvis is a gynecoid pelvis. So gynecoid pelvis में कौन सा presentation मिलेगा आपको? Can I write OA as occipito anterior presentation? So we have occipito anterior presentation. Is that clear? Is that clear? Yes. So 3 points. Most common type of pelvis, a rounded cavity, and occipito anterior presentation. Occipito anterior presentation. Okay, next one is going to be anthropoid pelvis. Now if we check this anthropoid pelvis, so this is oval shaped pelvis. This is oval shaped pelvis. This is oval shaped pelvis. Okay, and now when the occipito posterior is trying to get convert to the occipito anterior side, it is not able to convert. Why? Because it is not spacious. Okay, that's why the occipito posterior is remaining in the occipito posterior only. Now occipit on the posterior side, yes, this is gonna be the face of the baby, this is gonna be the pubis part. The delivery in case of an anthropoid pelvis is going to be face to pubis delivery. Is that clear? Is that clear? Now if a question will mention face to pubis delivery is happening in which type of pelvis, which of the following pelvis is responsible for the face to pubis delivery, what will be your answer? What will be your answer? Oval shaped pelvis or face to pubis delivery? So the answer goes to the anthropoid pelvis, oval shaped pelvis. Is that clear? Is that clear? So write it down. So anthropoid pelvis, anthropoid pelvis, it's second most common type of pelvis. It's second most common type of pelvis. Number first thing. Number second thing is it's oval shaped pelvis. Number second thing is it's oval shaped pelvis. Number third thing is that it has occipito posterior presentation. It has occipito posterior presentation, and the type of delivery, this can be the question as the type of delivery we have is a face to pubis delivery. The type of the delivery we have is face to pubis delivery. The type of the delivery we have is face to pubis delivery. Is that clear? That is about anthropoid pelvis. That's about anthropoid pelvis. So remember in short, sir, occipito anterior is gynecoid, and sir, face to pubis delivery is seen in the anthropoid pelvis, because this type of pelvis is called as oval shaped pelvis. Okay, now the third part, that's going to be triangle shaped or heart shaped pelvis. Okay, triangle shaped or heart shaped pelvis. Remember the hint, heart is cardiac and heart में क्या होता है? Arrest, cardiac arrest. So heart shaped pelvis having a deep transverse arrest. Okay, heart shaped pelvis में क्या होगा? Deep transverse arrest. So this android pelvis, if we discuss about the android pelvis, so this android pelvis, it's a male type of pelvis. So this android pelvis is a male type of pelvis. It is a male type of pelvis. Number first thing, so this type of pelvis, it is spacious posteriorly. So it's spacious posteriorly and narrow anteriorly. It is spacious posteriorly and narrow anteriorly. Okay. Third, It is heart shaped or triangle shaped. So it's heart shaped or triangle shaped. And deep transverse arrest occur in this type of pelvis. Deep transverse arrest occurs in android pelvis. Is that clear? Is that clear to everyone? So whenever a question mentions that deep transverse arrest occurred, whenever a question mentions that deep transverse arrest occurred, which type of pelvis can be? So the classical case, deep transverse arrest, okay, it rotated partially. So when it rotated partially because from the posteriorly it is a spacious pelvis, okay. So jab rotate ho gaya, but then it got stuck. That such type of stuck is called as the deep transverse arrest. So जब भी deep transverse arrest देखोगे, what will be your answer? So we are marking android pelvis. So we are marking android pelvis. ठीक है? Is that clear to everyone? Is that clear to everyone? Yes? चले. Okay. Now last one, it's gonna be platyploid pelvis. This is a rarest type. This, so in the android pelvis आप क्या main चीज याद रखोगे? So deep transverse arrest. How do we deliver? We deliver in case of a deep transverse arrest, we deliver with the help of a forceps, है ना? But yes, best answer to choose is gonna be cesarean section. Is that clear? So first normal vaginal delivery, second face to pubis delivery, third forceps or best by C-section, and then we have a platyploid pelvis. And this type of pelvis, if you see, it is transversely oval. It is transversely oval, okay. And this platyploid pelvis, so it's a rarest type. It's a rarest type of pelvis. It's the rarest type of pelvis. Number first thing. Number second, it's a flat pelvis. It's a flat pelvis, okay. Then face presentation is present. Face presentation is present. Now what is face presentation? When the face is touching the lower uterine segment, when the face is touching the lower pole of the uterus. Is that clear? That presentation is face presentation. Then again face have a different types depending upon the flexion and depending upon the diameter, okay. So rarest type of pelvis, flat pelvis, face presentation is present and the shape is transversely oval. So which type of pelvis is having a face presentation? That's going to be platyploid pelvis. So that is all about the pelvis and types. Remember, occipito-anterior rounded cavity, your answer goes to gynecoid. Second one, oval shaped face to pubis delivery, your answer goes to the anthropoid pelvis. Third one, android pelvis, it's a male type of pelvis, sir, heart shaped or a triangular shaped. So from the posteriorly it is spacious, that's why half partially it is rotating, but after some time it got stuck, which is called as deep transverse arrest. We are managing with the help of a forceps and best managed by cesarean. And last one is going to be platyploid pelvis, which is a rarest type having a face presentation associated. So you can write here face presentation. Face presentation. That's all. So rounded, oval, triangular, transversely oval shaped pelvis. Okay, is that clear to everyone? Is that clear to everyone? Yes. Now next topic is going to be teratogens. The next topic is going to be teratogens. Remember one hint about all these types of pelvises, okay, so that you will have a correct answer. Chalo, teratogens. Now all the drugs, you already know that all the drugs are not safe in the pregnancy because the drugs are having a teratogenic effect, okay. Now what are the drugs and what are the teratogenic effects, we'll learn, and whatever you know about these drugs and what are the alternatives of these drugs, write down in the comment section, okay. And this topic is important in view of pharmacology as well. Pharma se bhi puchte and from the obstetrics and gynecology as well, okay. Now starting with the first drug, anti-epileptic drug. Now if we talk about anti-epileptic drug, which drug is having a teratogenic effect, you already know, so phenytoin and valproate. If we use the phenytoin and valproate in case of a pregnancy, अगर हम phenytoin और valproate को pregnancy में use करते हैं, so what is the side effect they will cause? Write down. So they cause fetal head-and-toin syndrome. So they cause fetal head and twine syndrome. ओके, फीटल हेड एंड ट्वाइन सिंड्रोम, उसमें क्या होता है, अप टर्न नोज होता है बेबी में, ओके, एंड देयर इज डिस्टल डिजिटल हाइपोप्लेशिया होता है. सो दीज आर ऑल द फीचर्स ऑफ एन फीटल हेड एंड ट्वाइन सिंड्रोम. यू कैन राइट एन अपटर्न्ड नोज, अपटर्न्ड नोज. चलो, upturned nose, number first thing. Number second thing is, sir, safe anti-epileptic drug in pregnancy. What will be your answer? Safe anti-epileptic drug in pregnancy. Your answer is going to be levetiracetam or lamotrigine. What will be your answer for the safe anti-epileptic drug? Safe anti-epileptic drug in pregnancy, lamotrigine or levetiracetam. Remember these two drugs. Okay, remember these two drugs, lamotrigine and levetiracetam. Okay, safe. Second is gonna be AC inhibitors or angiotensin receptor block. Okay, now sir, what are the side effects of this drug? So they will cause fetal renal hypoplasia. Fetal renal hypoplasia. When they will cause fetal renal hypoplasia, there is a decreased blood supply to the kidneys. That's why after patient taking AC inhibitors and all, that's why they are having oligohydramnios as a side effect, because when the blood flow to the kidney will be decreased, the GFR will be decreased. When the GFR will be decreased, the fetal urine formation will be decreased, and you know that this fetal urine formation is the most important constituent of the amniotic fluid. So जब amniotic fluid ही कम हुआ, that's why patient land in the oligohydramnios. So what is fetal renal hypoplasia? इसकी वजह से क्या हो रहा है? So there is a decreased blood supply to the kidneys, and then correlate. It's a rapid regeneration. We cannot go everything in a detail, but whatever possible to crack the question, I'm delivering everything related to that. Okay, so decreased blood supply to kidneys. So there is decreased blood supply to kidneys, and when there is a decreased blood supply to the kidneys, the GFR is decreased. GFR is decreased, urine is decreased, and patient is having oligohydramnios. Patient is having oligohydramnios. Is that clear? Is that clear? Yes. Now third one is going to be alcohol. Alcohol will cause, you already know, sir, alcohol क्या कराता है? Fetal alcohol syndrome. Alcohol causes fetal alcohol syndrome. And the fetal alcohol syndrome में feature क्या होता है बेबी का? So baby is having abnormal brain development. So simple में लिखेंगे brain abnormality. There is brain abnormality. There is brain abnormality. Okay, followed by that lithium. You already know lithium is having a teratogenic effect on the heart. It causes Epstein anomaly. It causes Epstein anomaly. And pediatric question can be asked, which shape heart is seen in this Epstein anomaly? You already know that's going to be box shaped heart. So that's going to be box shaped heart. Okay, apart from this Epstein anomaly, lithium has other side effects as well. Okay, what are the other side effects of the lithium? So it causes the leukocytosis, it causes diabetes insipidus. It causes diabetes insipidus. We call it as lithium induced diabetes insipidus. One PYQ was asked, what is the drug of choice for a patient having a lithium induced diabetes insipidus? Lithium induced diabetes insipidus. What is the drug of choice? Lithium induced diabetes insipidus. Lithium induced diabetes insipidus. What is the drug of choice? Anyone from the pharmacology? We have three types of diabetes insipidus, right? जब antidiuretic hormone decrease होता है, that's what you call also vasopressin. Now these three types, it can be nephrogenic, it can be neurogenic, or it can be a drug induced. या तो kidney वाला cause है, either it can be a central cause, neurogenic, okay, or either we have drug induced. So what will be the drug of choice? Tell me, what will be the drug of choice? Sir, if a patient is having a neurogenic or a central diabetes insipidus, so the drug of choice is going to be desmopressin. ठीक है ना? Either if a cause is nephrogenic related to the kidneys, the answer is going to be thiazides. Remember, if the question asks lithium induced diabetes insipidus, then the answer goes to the amiloride. Very good. Then the answer is amiloride. So lithium induced is amiloride. Okay, lithium induced is amiloride. Followed by that we have neurogenic or central diabetes insipidus having a desmopressin as a drug of choice, and then amyloid. Okay, so these are all the side effects of a lithium. These are all the side effects of lithium. Clear to everyone? Side effects of lithium as well. Chale. Next drug is going to be indomethacin. Next drug is going to be indomethacin. Now, if we talk about the indomethacin, so indomethacin causes premature closure of ductus arteriosus. It can cause premature closure of ductus arteriosus. It causes premature closure of ductus arteriosus. Or in order to maintain the patency, which is the drug, we give the prostaglandin. Which prostaglandin is used to maintain the patency? Bata do. Pharmacology is very important. So whatever pharmacology we can integrate with respect to these drugs, whatever you know. So which drug you will use? Tell me. Which drug is responsible? Which drug is responsible? Which drug is used to maintain the patency? Chalo, बता दो. Prostaglandin, L-prostadil. Remember that, L-prostadil. ठीक है? और इसमें भी याद रखो indomethacin, ibuprofen for the closure. Okay? But if you give चलो indomethacin. चलो methimazole. Okay? Methimazole is used in case of an hyperthyroidism. Okay, so in case of a thyroid patient, so we use carbimazole and methimazole. Okay, but in second and third trimester, so if I use this carbimazole or methimazole in the first trimester, it will cause aplasia cutis or cutis aplasia. So what is aplasia cutis? There is an absence of dermis and epidermis. Absence of dermis and epidermis. Absence of dermis and epidermis. Okay, that's why in the first trimester, what is the drug we will use? In the first trimester, we will use propyl thiouracil, PTU in the first trimester. Second and third, carbimazole and methimazole. And for hypothyroidism, the drug of choice is going to be levothyroxine, L-troxin. Okay, na? L-troxin. Sir, warfarin will cause warfarin embryopathy. Warfarin will cause warfarin embryopathy. Okay, or what is the classical feature in warfarin embryopathy? There is nasal hypoplasia. There is nasal hypoplasia. There is nasal hypoplasia. Okay, followed by that, thalidomide. What is the side effect that the thalidomide will have? Phocomelia. Patient will have phocomelia. Patient will have phocomelia. Okay, abnormal lower limbs. ठीक है ना? Abnormal lower limbs, defected lower limbs. Okay, then methotrexate will cause clover leaf skull, which is called as craniosynostosis. Which is called as craniosynostosis. Okay, then paroxetine, it will cause pulmonary hypertension. Okay, what is the drug of choice for pulmonary hypertension? It's going to be bosentan. Remember, one more question was asked, which of the following drug can be used, which of the phosphodiesterase inhibitor can be used in a pulmonary hypertension? Your answer is going to be sildenafil. One more question was asked related to this, longest acting phosphodiesterase 5. Your answer is going to be tadalafil. Is that clear? Then next one is going to be erythromycin. Erythromycin will cause CHPS, congenital hypertrophic pyloric stenosis. So it can cause congenital hypertrophic pyloric stenosis. Is that clear? So CHPS is a classical side effect of a which drug? That's going to be a classical side effect of erythromycin. Okay, in which we have single bubble appearance. And in the from the surgery point of view, this question was already asked, that what is electrolyte abnormality over there? We have hypokalemic, hypochloremic, metabolic alkalosis, and the name of the surgery is Ramstead spirotomy. Chalo, that's about erythromycin. So remember, 3 antibiotics safe in the pregnancy. PCM. क्या क्या है? Penicillin, cephalosporins and macrolides. Which macrolide you will not give? Sir, except the erythromycin. Erythromycin we are not giving in case of a pregnancy, because it can lead to the CHPS. Okay, and last one, mifepristone, which is an anti-progesterone drug. What is the classical side effect? Sir, it causes Mobius syndrome. It causes Mobius syndrome. So it's all about a teratogenic effect of the drugs. Okay, teratogens. Is that clear to everyone? Yes. Yes, so remember guys, anti-epileptic drugs will cause fetal head and twine syndrome. AC inhibitors will cause fetal renal hypoplasia, decrease blood supply to the kidneys. And then remember one more thing, alcohol will cause fetal alcohol syndrome. Lithium will cause Epstein anomaly. Indomethacin will cause premature closure of ductus arteriosus. Methimazole will cause aplasia cutis, absence of dermis and epidermis. Warfarin will cause warfarin embryopathy, nasal hypoplasia. Thalidomide will cause phocomelia. Methotrexate will cause clover leaf skull, craniosynostosis. Paroxetine will cause pulmonary hypertension. Erythromycin will cause congenital hypertrophic pyloric stenosis, CHPS. And mifepristone will cause Mobius syndrome. Mifepristone will cause Mobius syndrome. Is that clear? Now let's move to the one more important chapter, that's going to be abortion. Important chapter, that's going to be abortion. Okay, now everything is clear so far. Now let's discuss what exactly is abortion. Okay, now if we talk about the WHO definition of this abortion, it means the pregnancy loss. So it means the pregnancy loss less than 20 weeks. It means pregnancy loss less than 20 weeks, or when the fetal weight is less than 500 grams. Fetal weight less than 500 grams, we call it as abortion. Okay, now abortion if more than 20 weeks or if more than 500 grams, we call it as intrauterine fetal demise. क्या बोलेंगे बच्चे फिर? So we call it as intrauterine fetal demise. We call it as intrauterine fetal demise. Now this loss of pregnancy, either it can be spontaneous loss of pregnancy. So spontaneous loss of pregnancy का क्या मतलब है? Spontaneous means it can be a type of a threatened abortion, it can be a type of a missed abortion, it can be a type of a complete, inevitable, incomplete. These are the spontaneous abortions. Now when I talk about the induced type of abortion that we induce with the help of a drugs, with the help of a surgery, okay, that is a induced abortion, medical and surgical abortion. And what is spontaneous? All the types, threatened, we have complete, incomplete. All right, and one more type is early pregnancy loss. What is early pregnancy loss? Okay, how do we define the early pregnancy loss? So early pregnancy loss means less than 12 weeks. Early pregnancy loss means less than 12 weeks, or when the crown rump length is less than 5 or CRL is 5 mm. We call it as early pregnancy loss. One more is a recurrent pregnancy loss. What is recurrent pregnancy loss? 2 or more than 2 consecutive abortions, back-to-back abortions. That is a recurrent pregnancy loss or habitual abortion. Okay, now types of abortion. We have 2 types of abortion. Now we have 2 types of abortion. Now what are the 2 types of abortion we have? So we have either embryonic. We have embryonic, in which the embryo is formed, and we have anembryonic. Anembryonic. So what is embryonic abortion? It's a type of the abortion in which embryo is present. It is a type of abortion in which embryo is present. Okay, and the crown rump length, is more than or equal to 7 mm. The crown rump length is more than or equal to 7 mm. Okay, so what is an anembryonic abortion? Embryo is absent. It's also known as, first of all, it's also known as blighted ovum. Blighted ovum. Okay, embryo is absent. So embryo is absent, and gestational sac is more than 25 mm. But main 2 features you will remember: there is no yolk sac or fetal pole. There is no yolk sac or fetal pole. This is an embryonic abortion. So what is embryonic abortion? So crown rump length more than or equal to 7 mm. And what is anembryonic? So there is no embryo present, there is no yolk sac, no fetal pole, and the gestational sac is more than 25 mm. The gestational sac is the more than 25 mm. Now talking about the causes of an abortion. Now, first trimester, the cause can be chromosomal. Usually, most common cause in the first trimester is a chromosomal. If related to the anatomy, uterus, cervix, or all, it can be usually second trimester cause, usually present. And in third trimester, there can be any maternal cause, or the cause can be anything. Okay, so let's discuss first the chromosomal causes of abortion. Okay, I'll repeat again. Abortion is loss of pregnancy less than 20 weeks. Okay, or the weight of the fetus is less than 500 grams, or the weight of the fetus is less than 500 grams. Number first thing. Number second thing is that two types of abortions we have. Number first is the embryonic abortion, in which the embryo is present. That's what we will understand. What is a missed abortion, complete abortion, incomplete, inevitable, and threatened. Okay, anembryonic, the embryo is absent, there is no fetal pole, no yolk sac, the gestation sac is more than 25 mm, the embryo is absent. Okay, that is an embryonic abortion. So और क्या बोलते हैं, we also call it as blighted ovum. Number first thing. Number second thing is that early pregnancy loss, if it is less than 12 weeks, अगर 12 वीक से पहले ही हो रहा है, then we call it as early pregnancy loss when the crown rump length is 5 mm. When the crown rump length is 5 mm. Clear to everyone? Yes. Now talking about a chromosomal cause. Now if you talk about the chromosomal causes, it's a most common cause in first trimester abortion. Okay, and write down, it's usually present in first trimester. So it's usually present in first trimester. It's usually present in first trimester. Okay, like we have trisomy 16, 18, and 21. 18 and 21, or we have monosomy 45XO, which is called क्या बोलते हैं, Turner syndrome, which is called Turner syndrome. क्या बोलेंगे बच्चे? Turner syndrome. Okay, now that is chromosomal cause of abortion. Usually in the which trimester? So they are usually in the first trimester. 1T is first trimester. Okay, they are usually seen in the first trimester. Now anatomical cause, something wrong with the anatomy. So something wrong with the anatomy will be something wrong with the uterus, and all the genital structures of female are coming from which duct? Tell me in the comment section. They are coming from Mullerian duct. So any Mullerian duct defect will lead to the second trimester abortion. So what can be the causes? So we have a septate uterus. So we can have a bicornate uterus, septate uterus, bicornate uterus, or we can have the incompetent cervix. Incompetent cervix, also called as cervical insufficiency. Also called as cervical insufficiency. Now let's discuss later on them. What exactly is a septate uterus, how you treat this, what exactly is a bicornate uterus, how you treat it, and what exactly is an incompetent cervix or cervical insufficiency, and how you treat it. Is that clear? Now maternal causes. Okay, and these usually are present, the anatomical are usually present in the which trimester? So they are present in the second trimester. They are present in the second trimester. Now maternal cause. Now this maternal cause can be present at any of the trimester. What can be the maternal causes? So it can be the infection, torch infection. So in the maternal causes we can have a diabetes. In maternal causes we can have a hypothyroidism. In maternal cause we can have APLA. It's a type of an acquired thrombophilia. Okay, antiphospholipid antibody syndrome. We can have cancers or syphilis. These are all the maternal causes of an abortion. These are all the maternal causes of abortion. Okay, the main question that will come from an abortion is either the presentation of a type of abortion and the management, is either anatomical causes and their management, or it's either the MTP, medical termination of pregnancy, drugs, dosage, and the time. Okay, these are very important questions that can come from abortion. Okay, Now let's discuss about recurrent abortion or habitual abortion. So I've already discussed that recurrent abortion is three or more than three recurrent abortion, three or more than three recurrent abortion. Okay, and it's more in which trimester? So they are more in second trimester. So they are more in second trimester. They are more in second trimester. Okay, now the most group of causes is the most common cause for recurrent pregnancy loss. Overall, it's endocrinopathies. So what includes in endocrinopathies? You already know. What is the most common endocrinological disorder in a reproductive female? Can you answer in the comment section? What's the most common endocrinological disorder in the reproductive females? Answer in the comment section. Anyone? Causes related to the abortion which will involve endocrinopathies. Yes, anyone? What are the causes? The answer is PCOS, because main reason of the PCOS is the pathophysiology of the PCOS is insulin resistance. That's why the most effective drug in the PCOS is what? The most effective drug in the PCOS is metformin, because follicles are not able to get enough glucose. That's why due to the thick stroma, follicles are not growing. So endocrinopathies, what are the disorders? It will include, yes, it will include diabetes. It will include hypothyroidism. It will include the PCOS. And remember, the most common endocrinological disorder in a reproductive female is PCOS. That's PCOS. Okay, followed by that, the most common cause of second trimester recurrent pregnancy loss. Second trimester recurrent pregnancy loss is going to be uterine cause. That's going to be uterine cause. And what can be the uterine causes? I've already told you that all the female genital structures are coming from where? They are coming from the Mullerian duct, and most common Mullerian duct defect is going to be septate uterus. Okay, also in second trimester, usually the causes is uterine cause. Okay, and in case of a first trimester recurrent pregnancy loss, we have a syndrome called as APLA syndrome. So what is this APLA syndrome? It's anti-phospholipid antibody syndrome. Okay, APLA syndrome. Now, after that, anatomical causes and management. Now let's discuss what exactly is septate uterus, what exactly is bicornuate uterus, and what exactly is incompetent cervix. Now if we talk about the septate uterus, it's the most common Mullerian defect. As I've already told you, all the female genital structures are coming from which duct? Mullerian duct. So any defect in this Mullerian duct, the outcomes will be septate, bicornuate. Okay. Second, it's the most common uterine cause. Of recurrent pregnancy loss. Okay. Third one, it usually causes second trimester abortion. It usually causes second trimester abortion. And the treatment for this, what is the management? What will be the management? Now look, it's a septate uterus. Okay, now what is the treatment? We go hysteroscopically and resect this part. So normal way, you are resecting this part, and this is a normal uterus now. Okay, so what is the management for this? So management is hysteroscopic resection. So what is the treatment for a septate uterus? If the image is given of a septate uterus and it mentions it's a classical case of an abortion usually in the 18 to 20 weeks around second trimester, and what will be the management for this particular condition? Your answer goes to hysteroscopic resection. Your answer goes to hysteroscopic resection. Okay, followed by that we have one more type of the uterus called as bicornate uterus. Okay, now in bicornate there are two horns. Okay, there are two horns present, and what will be the management, sir? What will be the management? You have to make it a single horn, and from two horns operating it to make a single horn, this is called as Stressman metroplasty, and this is because of, now these two horns, sir, it is because of incomplete fusion of Mullerian duct. It is because of incomplete fusion of Mullerian duct. It is because of incomplete fusion of Mullerian duct. Also, okay, we have bicornate uterus. So what is the management? We go for Stressman metroplasty, also called as, इसको और क्या बोलते हैं? Unification surgery. So we unify these two horns. That's called as unification surgery. From these two horns we make a single one horn. That is a Stressman metroplasty. So write it down. So bicornate uterus, it usually causes second trimester abortion. It usually causes second trimester abortion. Okay, and simply what is the management? You already know. So management is Stressman metroplasty. Management as a Stressman metroplasty or unification surgery, also. So we are unifying two horns into the single horn. That's what you call as unification surgery. And this two horns, it is because of an abnormal fusion, or it's because of an incomplete fusion of a Mullerian duct. And the most common Mullerian duct defect is going to be, the answer is going to be septate uterus. The answer is going to be septate uterus. So septate uterus, the management is hysteroscopic resection. So management for bicornate uterus is going to be Stressman metroplasty. Now the third one is incompetent os or short cervix. This incompetent os or short cervix, it is also called as, I've already discussed, it's also called as cervical insufficiency. It's also called as cervical insufficiency or incompetent cervix. Okay, now what exactly it means? It means that the cervix is short. How short? It is less than 2.5 centimeter, or you can write it's less than 25 mm. It's less than 2.5 centimeter, or it's also less than 2.5 centimeter. Okay, number first thing. Number second thing is, sir, this short cervix, it will predispose, sir, it will predispose to preterm labor. It will predispose to preterm labor and abortion. How? Because cervix will dilate. Okay, when the cervix will dilate prior to the labor, what will happen? Contents will come out, or sometimes prior to the labor it causes abortion. So the classical presentation of a patient having a cervical insufficiency, okay, presentation kaise hogi? Number first thing is, sir, there is painless dilatation. Okay, there is painless cervical dilatation. Painless cervical dilatation, followed by prolapse of membranes, and expulsion of fetus. So there is a painless dilatation of the cervix. There is no pain, and first what will happen? Prolapse of membranes will come out. Okay, membranes will come out, and followed by that what will happen? Fetus will come out. So either it will cause preterm labor, या तो preterm labor करा रहा है, or either it will cause an abortion, Is that clear? One question was asked, incompetent os, what should be the cervical length? Okay, it should be less than 2.5 centimeter. When it's less than 2.5 centimeter, that's when you can call it as cervical insufficiency or cervical incompetence or incompetent os or the short cervix. Is that clear? So rather giving in centimeters, they mentioned less than 25 mm. Don't get confused, है ना? Don't get confused. ठीक है बच्चे? Now sir, what will be the classical treatment for this patient? Now you already know that if this cervix, अगर ये cervix यहाँ पे है and this cervix is short, I need to close it down so that it will not dilate. There will not be any painless dilatation. So what I will do in order to prevent this preterm labor and abortion, I will put the cerclage. I will put the cerclage, and the cerclage on the cervix, most common cerclage I use, called as McDonald cerclage. What is the cerclage we use usually? So it's called as McDonald cerclage. Above that, we can also put one more cerclage called as Schrodkar cerclage, and उससे above अगर करेंगे abdominal cerclage, that's called as trans-abdominal cerclage. So what is the treatment? What will be the treatment for this particular condition? Sir, the treatment is the cerclage. So the treatment is going to be cerclage. And this cerclage, the most common one, the most common cerclage that we use, it's called as McDonald cerclage. So that's called as McDonald cerclage. The most common cerclage that we use, it's called as McDonald cerclage. Okay, and this cerclage is applied. This cerclage is applied on 12 weeks. This cerclage is applied by 12 weeks, and it's removed by 37 weeks. And when are we removing this? At 37 weeks. Okay, and in this particular case, whenever an incompetent os case is coming, either they will mention a patient had the history of a second trimester abortion, or the patient had a history of a preterm births. Okay, preterm births. So this classical case defines that it is a case of an cervical insufficiency. Is that clear? So what is the classical treatment? Cerclage. What cerclage? McDonald cerclage. Now my dear students, remember, in McDonald cerclage there is a possibility of a normal vaginal delivery, but when a patient is having a trans-abdominal cerclage, तो usually क्या होता है? Cesarean section. तो usually कैसे हम deliver करते हैं फिर? Cesarean section. Is that clear? Is that clear to everyone? Yes? Is that clear? So it's all about the anatomical causes of abortion and management. So in one word, write me down. So if it's a septate uterus, it's going to be hysteroscopic resection as a treatment. So if it is a bicornuate uterus, we have a unification surgery called as Stressman metroplasty. And if a patient is having the incompetent os or the short cervix, the treatment is going to be cerclage, and the most common cerclage we are using is McDonald cerclage. Okay, followed by that we can also use Schrodkar cerclage, or we can also use the trans-abdominal cerclage. Clear to everyone? Yes? Yes. Chale, next is going to be thrombophilia. The question have been repeatedly asked from the Aplas syndrome. So let's discuss what is thrombophilia, what are the types of thrombophilia, and what exactly is the treatment for thrombophilia. Is that clear? Now thrombophilia is a tendency to form a thrombus, to form the clot. Okay, now we have two types, either from the beginning, from the birth only, congenital only, that's an inherited thrombophilia, or either we have acquired thrombophilia, Now if we talk about the inherited thrombophilia, what can be the possible reasons for inherited thrombophilia? So patient can have a factor V Leiden mutation. Patient can have a factor V Leiden mutation. Okay, followed by that, patient can have protein C and S deficiency. Protein C patient can have protein C and S deficiency, or patient can have prothrombin gene mutation. Patient can have prothrombin gene mutation. Now these protein C and protein S, they are the natural anticoagulants, you know, and they are synthesized by liver, and they are vitamin K dependent, or anything wrong with the vitamin K will also have anything wrong with the protein C and S, or anything wrong with the liver will also have something wrong with the protein C and S deficiency. Is that clear? So whenever these anticoagulants okay, they are decreased, the tendency to form a clot is more, or the factor 5 leading mutation, or the prothrombin gene mutation. This is all related to what? Inherited thrombophilias. This is all related to inherited thrombophilias. Now what are the acquired thrombophilias? Acquired one mein we have a most important one, we have most important one that you have to study in view of an abortion chapter, that is anti-phospholipid antibody syndrome. So you just have to remember the 3 antibodies. What are the 3 antibodies which are seen in anti-phospholipid antibody syndrome? Number 1 is the anti-beta-2 glycoprotein. Number 1 is anti-beta-2 glycoprotein. Anti-beta-2 glycoprotein. Okay, followed by that we have anti-cardiolipin antibody. We have anti-cardiolipin antibody. We have anti-cardiolipin antibody. And the third one we have lupus anticoagulant. And the third one we have lupus anticoagulant. So what are the 3 antibodies? We have anti-beta-2 glycoprotein, we have anti-cardiolipin antibody, and we have lupus anticoagulant, and we have lupus anticoagulant. Is that clear? Is that clear? So remember 3 antibodies, and whenever examiner will ask a question, he will mention these 3 antibodies. Diagnosis is APLA. If he mentions the treatment, the management is going to be the low molecular weight heparin, plus you are giving an antiplatelet drug. The antiplatelet drug we use usually is aspirin. So low molecular weight heparin plus aspirin. Low molecular weight heparin plus aspirin. Is that clear? Okay, let's not go in a detail much. Okay, it's a rapid revision session, so I'm trying to deliver it in a very concise manner. Clear, bacha? Yes, we have everything discussed in our main sessions as well, main classes as well. What exactly are the etiologies and all? Is that clear? Now clinical presentation of abortion. Now how exactly the question of acquired thrombophilia will be asked? Okay, how exactly the question for acquired thrombophilia will be asked? Look, this is exactly the same question that was asked in a NEET PG 2021. A young pregnant female comes to the LR, okay, with the complaints of bleeding and abdominal pain at 10 weeks. It gives the history of a first pregnancy loss at 8 weeks, second pregnancy loss at 11 weeks. Okay, now I've already discussed the most common cause for first trimester recurrent pregnancy loss, APLA. ठीक है ना? Previous report reveals that both fetus were morphologically normal without any gross congenital anomalies. That means that there is no any anatomical defect, there is not any chromosomal defect. She had a preterm delivery due to the early onset preeclampsia. The lab work reveals, that's main important part, there is an anti-cardiolipin antibody. The lab work reveals there is anti-cardiolipin antibody. When you see in the question that there is an anti-cardiolipin antibody, what will be your most appropriate treatment? तो क्या होगा treatment बच्चे? What will be the most appropriate treatment? When there is an anti-cardiolipin antibody, what will be your most appropriate treatment? So I'll go with the low dose aspirin and low molecular weight heparin. Okay, so what is your diagnosis? Our diagnosis is APLA, anti-phospholipid antibody syndrome. Okay, sometimes one question will be also asked with the history. They will not mention the anti-cardiolipin, they will just mention that a patient wants to get checked preconceptionally. Okay, now she wants to get checked preconceptionally for the recurrent pregnancy losses, and what will be the investigation you can do? They will mention HbA1c, they will mention TSH levels, they will mention blood pressure regularly, and they will mention lupus anticoagulant. This is the exact same question that will be framed, that preconceptionally if a patient wants to check or patient wants to do some investigations, which are the following investigations she can do preconceptionally for the recurrent pregnancy loss? Your answer goes to any antibody that will be given, lupus anticoagulant. Lupus anticoagulant. Is that clear? Is that clear to everyone? Is that clear to everyone? Yes? Chale. Now clinical presentation of abortion. Now type of abortion, how the patient of abortion will present. You already know that the patient of abortion will have 2 symptoms. First of all, patient will complain of pain abdomen, and next patient will complain of bleeding per vaginal. Next patient will complain of bleeding per vaginal. First is pain abdomen, second is bleeding per vaginal. Second is bleeding per vaginal. On PV examination, okay, now on per vaginal examination, you have to remember either the os will be closed, or the os will be open. या तो os closed होगा या तो os open होगा. Now depending upon the type of abortion, we'll discuss what will be the per abdominal examination, period of amenorrhea, and the size of uterus. Okay, or second will be the per abdominal examination. Is it is increased, the height of the uterus is increased, or height of the uterus is decreased with respect to the period of gestation. Second, per vaginal examination, either the os will be open, the os will be closed. Third question to the patient that will ask, type of bleeding. What does that type? Either is a complete, did you pass any clots, did you pass nothing at all, did you had any episodes of bleeding? Okay, these are all the questions that you will ask to the patient. Now on per abdominal examination, when you see that the fundal height or the height of the uterus, the fundal height is equal to the period of gestation, and the fundal height is equal to the period of gestation. This is called as threatened abortion. This is called as threatened abortion. When the fundal height is corresponding to the period of gestation, on per vaginal examination, the internal os is closed. Okay, so nothing happened. Door is closed. Height of the uterus is corresponding to the period of gestation. This is a classical case of which type of abortion? So this is a classical case of a threatened abortion. This is a classical case of a threatened abortion. Okay, and what will be the management for that particular condition? So we are giving progesterone plus bed rest. Okay, so what will be the management of a patient having a threatened abortion? So patient progesterone plus bed rest. There is nothing wrong. Okay, the fundal height is corresponding to the period of gestation or period of amenorrhea, and the os is closed. Okay, second one, inevitable abortion. Second one is inevitable abortion. So what is inevitable abortion? Fetus is in the process of expulsion. Fetus is in the process of expulsion and the products are bulging. Now what is inevitable abortion? The fetus is in the process of expulsion. So when you go and check, you will see the products are bulging, or they will mention the products are hanging. The products are just in the process of going out. Okay, and on per abdominal examination, the fundal height, on per abdominal examination, the fundal height is less than or equal to period of gestation. The fundal height is less than or equal to the period of gestation, and the internal os will be open because products are hanging, products are bulging, they are coming out. So period of gestation, the fundal height will be less than the period of gestation because some products are passing, or if they have not passed, either it can be equal to the period of gestation. And on checking the per vaginal examination, the os is open. Remember, I means open, so incomplete and inevitable means os is open. Shortcut. Okay, what will be the management? So management will be suction and evacuation. What will be the management? So the management will be suction and evacuation. The management will be suction and evacuation. ठीक है ना? So fundal height less than the period of gestation, internal os is open, management is suction and evacuation. This is a classical case of which type of abortion? So it's going to be inevitable abortion. This is going to be inevitable abortion. So how examiner will ask the question? A female is coming to you with the complaints of pain, abdomen and bleeding. On per abdominal examination, the fundal height is less than the period of gestation. Okay, the os is open. What will be the management? So your management should be, you should know that the clinical presentation that has been given to you is a classical case of an inevitable abortion, and inevitable abortion where the management is suction and evacuation. The suction and evacuation. Next is going to be incomplete abortion. Now these types of abortion that we are studying, they're all embryonic abortion. Embryonic abortion क्या था? जिसमें embryo present होता है, जिसमें embryo present होता है, and CRL is more than 7 mm. CRL is more than 7 mm. If CRL is 5 mm and less than 12 weeks, we call it as early pregnancy loss. So what is anembryonic? The embryo is absent. Gestational sac is more than 25 mm. There is no yolk sac or no fetal pole. It's also called as blighted ovum. क्या बोलते हैं बच्चे उसको? Blighted ovum. Now third type is called as incomplete abortion. What is incomplete? The abortion has not been completed. So write it down. Abortion occurred. So an incomplete abortion occurred, but some products of conception are retained inside. So some products of conception are retained inside. Okay, this is a classical case of an incomplete abortion. That means a patient will complain, sir, I passed some clots, but some clots are still inside. They are retained inside. Such type of abortion is called as incomplete abortion. Now, based upon a presentation, you already know if some of the clots have passed, the height of the uterus will be less than the period of gestation. Okay, number first thing, os will be open. Number third thing, patient will give the history of expulsion. Patient will say, sir, I passed. Patient will give the history of expulsion of products of conception. Patient will say, doctor, I passed some clots back home, and now on the per abdominal examination, the height of the uterus, that's what you call the fundal height, the height of uterus will be less than the period of gestation. It will be less than the period of gestation. And on per vaginal examination, the os will be open. Again, what will be the management? So we go for suction and evacuation, and we go for suction and evacuation. Okay, simple question will be asked that a female is coming to you with the complaints of pain, abdomen and bleeding. Okay, upon the examination, patient is giving the history of expulsion. Per abdominal examination, the size of the uterus is less than the period of gestation, os is open. What will be your diagnosis? So your diagnosis, you should remember, the diagnosis is incomplete abortion. That means abortion has occurred, but some of the part of conception, some of the products of conception, they are still inside, they are retained. Okay, followed by that we have a missed abortion. Now missed abortion, sir, abortion occurred but remain unnoticed. Sir, why this remain unnoticed? Because it's usually asymptomatic. What does asymptomatic mean? There is pain or there may not be any pain. There is slightly spotting. There is not complete bleeding. There is slightly spotting. So it's usually what? Unnoticed. Or it's also written that with the no warning sign and symptoms. If the abortion occurred with a crumpled sac with no cardiac activity, the classical diagnosis of a missed abortion. So what is missed abortion? Sir, it's usually abortion occurred, remain unnoticed because it's mostly asymptomatic. It's mostly asymptomatic or with no warning signs and symptoms. With no warning signs and symptoms. Okay, if we talk about the per abdominal examination, fundal height is less than the period of gestation. And on per vaginal examination, the internal os is closed. And the management, we have dilatation and curettage. So we have missed abortion. Okay, so abortion, it remain unnoticed because there is spotting and just there can be pain or no pain at all. So it will be mentioned in the question that there's a crumpled sac with no cardiac activity. Remember the hint line, crumpled sac with no cardiac activity. Okay, crumpled sac with no cardiac activity. The answer is missed abortion. Now इसमें क्या है? Os close है, so we'll go for dilatation and curettage. Is that clear? It's crumpled sac. That's why the fundal height is not equal to or more than the period of gestation. It's not going beyond that stage. Okay. Now complete abortion. What is complete abortion? Sir, abortion occurred. Okay, all products of conception are expelled out and the uterine cavity is empty. So whatever was inside, it's all came out. Okay, on per abdominal examination, there can be a normal uterine size. And this normal uterine size is because the uterus is empty. Because the uterus is empty. Okay. And on per vaginal examination, the internal os is closed. Now whatever was inside in case of a complete abortion, वो सारा क्या आ गया, बाहर आ गया. Okay, the uterus is empty. So what will be the management? So no intervention is needed. You don't have to do anything. Just do USG. Okay, do USG to rule out a retained products of conception. Just do USG to rule out the retained products of conception. Is that clear? Is that clear to everyone? Yes, because after the abortion has occurred, we have to rule out, because if the RPOCs is more, okay, that's why after the normal vaginal delivery or after the abortion, we usually prescribe a patient a cytolog, misoprostol, so that whatever is inside, it will be thrown out. Okay, na? Prostaglandin E1, misoprostol. Or we also do USG. If it's more, we might need a curettage. Okay, we might need a curettage. So that's why after the complete abortion, we do USG to rule out retained products of conception. Okay. Then an embryonic pregnancy. I've already told you that it has a clinical picture. It has a symptoms. What are the symptoms? So it has a symptoms, usually a small spotting, or it can be asymptomatic. It is same like a missed abortion, but the only difference is in missed abortion embryo is present, but in anembryonic is blighted ovum. Okay, na? Embryo is absent. Okay, size of the uterus is less than the period of gestation, sir. The internal os will be closed. On the USG, there is gestational sac. I've already told you, so there is gestational sac, but no pole. The treatment is dilatation and evacuation. We also use medical methods as well, drugs. Is that clear? So that is all about the abortion. Is that clear? Yes, clear to everyone? So types of abortion, sir. Let's have a quick recap. So types of abortion, the patient will complaining of a pain, abdomen and bleeding, first thing. So then I will check the height of the uterus with respect to the period of gestation. So if it is normal, that there is no change, it's equal. Along with that, the os is closed. I diagnose it with the type of an abortion called as threatened abortion. The classical treatment for the threatened abortion, so bed rest plus progesterone. Is that clear? Next, so incomplete abortion or inevitable abortion. So in both these types of abortion, usually the fundal height is less than the period of gestation. Number first thing. So both these abortions, the os is open. So the clinical picture of an inevitable will be the products are bulging or the process is going on, the expulsion is going on. And in case of an incomplete abortion, patient already passed some clots, patient will give the history of expulsion. Is that clear? And both suction and evacuation will be the treatment. Okay, followed by that we discuss about the complete abortion. So what is complete abortion? Complete abortion means that the process is complete, the uterus is empty and the os is closed. Height of the uterus, it's kind of normal uterus because nothing is inside, and treatment is no intervention is needed, but we can still go for a USG in order to rule out the retained products of conception. Is that clear? Then followed by that we discuss about missed abortion. Some missed abortion is a type of an abortion in which there are no warning signs. It's usually asymptomatic. Okay, and there is a crumpled sac with no cardiac activity. जब cardiac activity ही नहीं थी, crumpled sac था, baby बड़ा ही नहीं. That's why the height of the uterus is less than the period of gestation. That's why the fundal height is less. Okay, followed by that, what will be the treatment? So dilatation and evacuation. Okay, os is closed. Then anembryonic, we have a blighted ovum. Again, we'll go for the dilatation and evacuation. Os is closed. It is also asymptomatic. There is no embryo present, but gestational sac is present with a no pole. That is all about the types of abortion. Okay. Now, in one table, if we will recall all these types of abortion, guys, threatened, I've already discussed that patient will complain of a vaginal bleeding with a pelvic pain and bleeding. So uterine size, it's corresponding to the gestational age. Okay, height of the uterus is corresponding to gestational age. So os is closed. Okay, and fetus is alive. There is a retroplacental hemorrhage present, and management you already know, bed rest plus progesterone. Okay, rest open wale mein suction and evacuation, close wale mein you have to go for dilatation and evacuation. For complete abortion sir कुछ नहीं करेंगे, just do USG in order to rule out RPOCs. Inevitable abortion, I means open, so in both the conditions, inevitable and incomplete, OS is open. But when you do a inevitable type of abortion, when you do the pervaginal examination, you will see open with palpable concepts. That's what I have mentioned. The products are bulging or the products are hanging. The process of expulsion is going on. Okay, and uterine size can be same or smaller. Size can be same or smaller. Again, bleeding and pain will be the clinical feature present. Then suction and evacuation will be the treatment. Based upon the incomplete one, so bleeding may be heavy in case of an incomplete abortion. The uterine size is smaller and os is open, and products of conception are partially retained. That's what I have mentioned, that the patient will give the history of expulsion, that yes doctor, I have passed some clots, now rest of the clots are still retained inside, so you will go for suction and evacuation. Followed by that, we have a complete type of abortion. What is complete type of abortion? The vaginal bleeding can be present or there will be a absent trace, because whatever was inside is already passed out. The uterine size can be smaller or normal uterine size, or normal uterine size, or normal uterine size. Os is closed, nothing to be done. Uterine cavity is empty. You just do USG in order to rule out retained products of conception. In order to rule out retained products of conception. If we talk about a missed abortion, sir, missed abortion, vaginal bleeding, trace or brownish in color. Okay, very less. There is no pain. Okay, written. That's why it's asymptomatic. Uterine size is smaller, there is os is closed, it's blighted ovum or the fetus without cardiac activity, or without cardiac. Blighted ovum क्यों? अगर embryo present नहीं है तो blighted ovum है. अगर embryo present है, then it's a case of a missed abortion. Is that clear? Now one more type is related to the infection, that is septic abortion. Okay, so in septic abortion, what will be the presentation of a patient? So the vaginal discharge, purulent or foul smelling due to the infection, and with the features of sepsis, there will be high grade fever, associated foul smelling discharge. Okay, all these things. And then uterine size may be variable or larger because of an sepsis. Infection will be there, infection may inflammation hoga, that's why the uterine size is bigger. Os is open, and products of conception, there's a presence of a foreign body, and there can be a free fluid present in the peritoneal cavity or the pouch of Douglas. So any type of abortion related with fever, foul smelling discharge, increased uterine size, you take a classical diagnosis for septic abortion. Is that clear? That was all about the abortion chapter. That was all about the abortion chapter. Now one question, if they ask, a 35-year-old, now answer me, a 35-year-old lady gravida 3 parao livo A2, that means she's third time pregnant and previous 2 abortions she had. Okay, present with 16 weeks pregnancy. Okay, present with 16 weeks pregnancy, pain abdomen. The USG bedside was done. It shows the funneling of the cervix. The cervical length was 21 mm. What will be the best management for her? What will be your answer for this particular question? What is your diagnosis? What will be your diagnosis? Main classes, I'll let you know. It will be uploaded on my handle, hopefully after the August or in the August online. So we are going for the McDonald stage. Very good, guys. We are going for the McDonald stage or McDonald's cerclage. Is that clear? Yes, we apply this McDonald's cerclage at how many weeks? Sir, we apply at 12 weeks and we remove by 37 weeks. Yes, my dear students, this is a cervical insufficiency. This is a cervical insufficiency or incompetent os. There is a painless dilatation of the cervix, due to which there is a prolapse of membranes, followed by there is prolapse of fetus. That's why the classical case will be always given with a recurrent abortion. And you see there is para 0, that means 28 week के बाद गया ही नहीं है. It's prior to 28 weeks. It's usually in the second trimester. It's usually the anatomical cause, and the cervical length given is 21 mm. Okay, is that clear? So that is about the chapter abortion. Stressman metroplasty unification surgery, incompetent cervix, you already know cerclage. You already know about the cerclage. Okay, remember about the causes. First trimester usually we have chromosomal, second anatomical, third it can be any. Okay, remember the teratogenic effect, anti-epileptic drugs, fetal head and twine syndrome, ACE inhibitors, fetal renal hypoplasia, alcohol, fetal alcohol syndrome, lithium Epstein anomaly, indomethacin, premature closure of ductus arteriosus, methimazole, aplasia cutis, warfarin embryopathy. Okay, that's why we use low molecular weight heparin. Is that clear? Organogenesis के बाद we usually use warfarin, but again by 36 weeks we have to stop and start low molecular weight heparin. ठीक है ना? Then thalidomide, phocomelia, Methotrexate, clover leaf skull, craniosynostosis. Paroxetine will cause pulmonary hypertension. Erythromycin will cause congenital hypertrophic pyloric stenosis. Mifepristone will cause Mobius syndrome. And remember the 3 antibiotics that are safe, usually PCM, penicillin, cephalosporins, and macrolides. Which macrolide you will not give, bache? Sir, will not give the erythromycin. Okay. Before that, we discuss about the types of pelvis. The types of pelvis, we discuss that the most common type of pelvis is going to be the gynecoid pelvis. It's having a rounded cavity, so that's why the all occipito-posterior presentation they convert to the occipito-anterior, and they are delivered with the help of a normal vaginal delivery. They are delivered with the help of a normal vaginal delivery. Followed by that, we discussed about the type gynecoid. Followed by that, anthropoid oval shaped pelvis. We have occipito-posterior presentation. That's why face to pubis delivery is happening, because occipito-posterior is not converting to occipito-anterior. So जब भी face to pubis delivery आएगा, oval shape आएगा, anthropoid market. Followed by that, we have triangular shape to the heart shape, which is spacious posteriorly and narrow anteriorly. When it's spacious posteriorly, it tries to convert to the occipito anterior, but in mid it gets stuck. That stuck is called as a deep transverse arrest, and that deep transverse arrest is managed by with the help of a forceps and best managed by cesarean section. Number first thing. Number second thing is, remember, it is a male type of pelvis. ठीक है ना, android pelvis. Number 4 one was a platyploid pelvis. It's a transversely oval shaped pelvis associated with the face presentation. It's associated with the face presentation. Okay. Followed by that, we discuss about an ectopic pregnancy. Ectopic pregnancy, pregnancy outside the uterus. है ना? Most common site is fallopian tube. Most in fallopian tube is ampulla, followed by isthmus, infundibulum, and interstitium. Remember, interstitium is the narrowest and ampulla is the widest. Ampulla is also the site, most common site for genital tuberculosis and also the fertilization. Okay. Earliest to rupture is isthmus. Okay. Followed by that, classical 3 symptoms of patient having an ectopic pregnancy: amenorrhea, pain in abdomen, and bleeding per vaginal. But अगर ruptured ectopic pregnancy दिया हुआ है, so due to the hemiperitoneum and the excessive bleeding inside, there is a irritation of a diaphragmatic part. Okay. And peritoneal cavity, patient is having a referred pain called as shoulder tip pain, and this sign is called as Danforth sign. And due to this hemiperitoneum, the hypovolemia occurred, cardiac output is decreased, blood pressure is decreased. Okay. And that's why patient is also having a transient attack, syncopal attacks. Okay. Then ruptured में सबसे पहले resuscitation करोगे, and there is only one surgery that you go for, total salpingectomy. If patient vitals are unstable, you go with the laparotomy. If vitals are stable, you can go laparoscopic plus laparotomy. Is that clear? There is no role of beta HCG. There is no role of hemodynamics. There is no role of beta HCG. There is no role of a size of ectopic. Is that clear? If unruptured, sir, I can either go medical management or I can either do the surgical management. So medical management, when the beta HCG is less than 5000, when the size is less than 4 centimeter and patient is hemodynamically stable. So opposite to that, if beta HCG is more than 5000, more than 4 centimeter size, hemodynamics is unstable, signs of ruptures are present, you go with the surgical management. Remember the name of the criteria. Cervical ectopic is Rubin's criteria. Ovarian is Spiegelberg's criteria. Abdominal is Study-Ford. Caesarean ectopic is Gordon's criteria. Okay, investigation of choice is TVS, and if gold standard, it's laparoscopy. If the investigations are inconclusive at 6 weeks only, you go with the beta HCG levels, and if these beta HCG levels are doubling in 48 hours, this is a classical case of an intrauterine pregnancy. If it is increased by 33% after 2 days, it's a case of an ectopic pregnancy. If there is a fall by 50%, that's gonna be a case of abortion. Is that clear? Everything is clear till now? So we move to the next question. Everything is clear so far? Everything is cleared so far? Please update me in the comment section. All good? Yes? Yes, sir. Okay. Let's have a 10 minutes of break and then we begin. Okay. Let's have 10 to 12 minutes of break and then we proceed with next part. Is that clear, bache? Okay. We'll start sharp after 10-12 minutes. Okay, so see you guys. Be connected, don't leave. I see you after 10 minutes. 10 to 12 minutes, we again start. Yes guys, I'm audible and visible, so let's start. Yes. Can we start? Yes. So let's begin with the next question. A 28-year-old woman has been on OCPs for 5 months. Now a 28-year-old woman is there. She's on OCPs for 5 months. She presents to the OPD with a 6 weeks amenorrhea. Now she's coming to you with a 6 weeks amenorrhea and her UPT is positive. Her UPT is positive, which is the most accurate method to determine the gestational age in the woman. Now she is not sure about her dates. Okay, now she's not sure about her dates. Now what is the most accurate method to determine the gestational age? Okay, tell me guys. Yes, multiple answers. Answer me. If a woman is not sure about her dates, if she would have been sure about her dates, we go with the formula, Nagli's formula. Yes, but now she doesn't know about her dates, so the fetal estimation, okay, so that the fetal age estimation, it's classically best given with the help of a crown rump length. Very good, correct. So the answer is going to be crown rump length. The answer is going to be crown rump length on ultrasound. The answer is going to be crown rump length on ultrasound. Okay, now let's write about the best parameters for the estimation of the fetal age. Okay, now depending upon the trimester, if we talk about the first trimester, we go for crown rump length. The first trimester we usually go for crown rump length. Okay, in case of a second trimester, sir, second trimester we go and check for the biparietal diameter, BPD, biparietal diameter. Okay, and if we talk about the third trimester, we have femur length. In third trimester we check femur length. Okay, and if the question will be asked that overall best for the fetal estimation age, for the age of fetal estimation of fetal age, the overall best, so our answer goes to, for overall best, bache, the answer goes to crown rump length. Overall best is going to be crown rump length. Is that clear? Is that clear? Yes, so best one is crown rump length. Okay, I will also discuss about a Nagli's formula. Okay, how do we check the estimated date of delivery with the help of a Nagli's formula? What is Nagli's formula? Okay, now prior to that we were discussing about the fundal height. Okay, I will give you some important parameters of the fundal height, usually 12 weeks, 24 weeks and 36 weeks. Okay, so how do you remember? So 12 weeks, we can have 20 weeks, 24 weeks and 36 weeks. 12, 24. Okay, so we remember this with a formula called as PUX. Which formula? PUX. Okay, 12, 24, 36. Okay, so 12, 24, 36. So how do you remember? At 12 weeks it's P, that is pubic symphysis. At 24 weeks it's U, that is upper border of umbilicus. U is umbilicus, U is upper. So upper border of umbilicus is 24. At 36 it is cephus sternum. It is cephus sternum. So right, at 12 weeks it is pubic symphysis. So at 20 weeks, at 24 it is upper border of umbilicus. At 20 weeks it is lower border of umbilicus. It is lower border of umbilicus. At 24 weeks it is upper border of umbilicus. It is upper border of umbilicus. And at 36 weeks it is cephus sternum. 36 weeks, it's safest gestation, and beyond that the head is not palpable, and beyond that the head is not palpable, and beyond that the head is not palpable. Is that clear? So that is about the fundal height. That is about the fundal height. Is that clear? Is that clear? So remember the formula: cerpux, pubic symphysis, upper border of umbilicus, and safest sternum, and safest sternum. Okay, now followed by that we have also triple test and the quadruple test. The question has been asked multiple times: what are the components of the triple test? So you'll remember the components of the triple test. Number first thing is beta HCG. Number first one is beta HCG. Okay, then we have alpha fetoprotein AFP, plus we have estriol. This is a triple test. Okay, this is triple test. Okay, now if you talk about a quadruple test, we have four things. We have triple test plus inhibin A. So quadruple में क्या क्या आएगा? बीटा HCG plus alpha fetoprotein plus estriol plus inhibin A. It is not the inhibin B, it is inhibin A. It is not the inhibin B, it is inhibin A, which is the answer. Is that clear? Is that clear to everyone? Yes, triple test and the quadruple test. Okay, now tell me, my dear students, inhibin is a marker of which ovarian tumor? 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 I can give the hint. The bodies classically seen in that tumor is called exoner bodies. It started with a G. Which tumor having a marker of inhibin? Which tumor we have a marker inhibin? Granulosa cell tumor. Very good. The tumor is granulosa cell tumor. Okay, it's a estrogen secreting tumor. A lot of estrogen. Okay, it's a hyperestrogenic state. Question was also asked: which of the following is a hypoestrogenic state? The options were, listen to the question: which of the following is a hypoestrogenic state? Granulosa cell tumor, tamoxifen, endometrial cancer, and the last one was low BMI. What will be your answer? And one more option was low BMI. What will be your answer for this question? What will be the answer for this particular question? Yes, which of the following is a hypoestrogenic state? Estrogen कम किस condition में होगा? Tamoxifen, endometrial cancer, GCT, low BMI. Very good, sir. Low BMI. When the low BMI will be there will be low cholesterol and fats. Low cholesterol fats because androgens कहाँ से आते हैं? The precursor is cholesterol only. So low BMI means hypoestrogenic state. Is that clear? Sir, tamoxifen is a drug belong to the class selective estrogen receptor modulator, SERM, and the side effect of that drug is endometrial hyperplasia, which can predispose to the endometrial cancer. So that means hyperestrogenic state. Okay, GCT always, I already told that there are the estrogen secreting tumors, granulosa cell tumor, and endometrial cancer also. There is high estrogen level. So low BMI is a hypoestrogenic state. Okay, now sometimes we need to calculate the estimated date of delivery. Okay, and the formula that for that we use is called as Naegeli's formula. Okay, but so this Naegeli's formula that we use, it is applicable for regular cycles. First thing, so it's applicable for regular cycles. When I talk about regular cycles, that means the normal length of a cycle, the normal cycle is 28 days, after every 28 days, plus minus. So when I can call it as oligohydramnios beyond 35, when I can call it as polyhydramnios less than 21 days. So we have, okay, normal cycle 28 days, oligomenorrhea more than 35 days, polymenorrhea less than 21 days, menorrhagia excessive bleeding more than 80 ml, hypomenorrhea less than 10 ml, normal bleeding 20 to 25 ml or 30 ml bleeding. Is that clear? These are the basic definitions you should know. Okay, now the Naegeli's formula from LMP, you have to do 9 months plus 7 days. Okay, you have to add on 9 months plus 7 days. Now these 9 months plus 7 days, okay, you will add on in the last menstrual period. LMP will be given, but it is only applicable for regular cycles. That is how many days? That is 28 days. So if in equation it will be given that the cycle is 29 days. The cycle is 32 days. The cycle is 25 days. Can we apply this formula? Yes, you have to apply, but with changes. So what are the changes? So if prolonged cycle, if long cycle, add the extra days. If short cycle, subtract the days accordingly. Is that clear? For example, if a patient you have given the LMP of, if LMP of 25th of March is given, calculate the EDD. Now do guys, cycle is 28 days. Okay, now tell me the answer for this particular question. Simple, LMP is 25th of March, calculate the EDD. So what will be the EDD? What will be the EDD? By December it will be 9 months. Add on the days. 26, 27, 28, 29, 30, 31st, 1st. It will be 1st of January. It will be 1st of January. Is that clear? It will be 1st of January. Okay. Now if it is given that the cycle is 30 days, so you will do 9 months plus 7 days plus 2 days. So answer is going to be 3rd of Jan. If it is 25 days, so you're going to subtract the given days. Answer lands minus 3 days. 9 months plus 7 days minus 3 days. Is that clear? That's a Negley's formula. Is that clear to everyone? Yes, write down in the comment section, bache. Yes, is that clear to everyone? Is that clear to everyone? Yes. Chalo. Now a patient came to the antenatal clinic for routine visit. The level 1 scan was performed, which shows a knuckle translucency of 4 mm. The doctor recommended to perform a quadruple test in second trimester. Which among the following is not a result of positive test? Now you are going to perform a quadruple test. Now the quadruple test you are going to perform, which of the following will not be the result of the positive test? Now answer me. Which of the following will not be the result of a positive test? We just discussed what are the components of a triple test and what are the components of a quadruple test. So triple में क्या क्या आती है 3 चीज़ें, बीटा HCG, अल्फा फीटोप्रोटीन प्लस estriol, and quadruple में triple plus inhibin A. So which of the following will not be a result? Which of the following is not a result of a positive test? What will be your answer? Which of the following is not a result? Sir, answer is going to be inhibin B, because inhibin A is seen. Okay, so you have E3, AFP, HCG and inhibin A rather than inhibin B. Is that clear? So this is the answer. Chale. Now let's discuss one more important chapter, that's going to be postpartum hemorrhage. Now let's discuss one more important chapter, that's going to be postpartum hemorrhage. Now my dear students, what is postpartum hemorrhage? Sir, it is a bleeding after the delivery. Listen carefully, it's a bleeding after the delivery. Okay, now why exactly this bleeding is occurred? Sir, it occurs due to the complication. So it is a complication of a which stage of labor? So it's a complication of a 3rd stage of labor. It is a complication of a which stage of labor? So it's a complication of a 3rd stage of labor. So what is 3rd stage of labor? So 3rd stage of labor is delivery of the baby to the delivery of the placenta. Yes, 3rd stage is a delivery of the baby to the delivery of the placenta. Okay, now in order to prevent such complications, we have active management of 3rd stage of labor. Okay, now what is active management of 3rd stage of labor? We give the uterotonic agent, we go for the delayed cord clamping, we go for the delivery of the placenta with the help of cord and control cord traction, and we go for an assessment of uterine tone, earlier called as uterine massage. This is what is AMTSL. Okay, I'm again not going too much in the detail, I cannot explain fully everything, but let me tell you. Okay, so postpartum hemorrhage is a complication of a which stage of labor? 3rd stage of labor. So what is the 3rd stage of labor? Delivery of the baby to the delivery of the placenta. Sir, if this 3rd stage of labor is not handled properly, if there is a mismanagement of the 3rd stage of labor, we have a complications of the 3rd stage of labor. And what are the complications that we have during the 3rd stage of labor? So we can have a bleeding, postpartum hemorrhage, we can have upside down of the uterus, is called as uterine inversion, we can have amniotic fluid embolism, and we can have shock. In order to decrease these complications, we have a management of 3rd stage of labor which is actively followed in order to prevent such complications. In order to prevent the postpartum hemorrhage, the management is called as active management of third stage of labor. What is that called, bache? So that is called as active management of third stage of labor. Now what exactly is this active management of third stage of labor? So I'm giving the first uterotonic agent which will maintain the tone of the uterus. What is the drug I'm giving? I'm giving oxytocin as a prophylactic drug, 5 to 10 international units. Followed by that, I'm going for the delayed cord clamping. Followed by that, I'm going for a control cord traction. I'm having a particular control on the cord and try to remove the placenta with this method, which is also called as Brand and Enders method. Because if I'm doing the sudden cord traction, अगर मैं suddenly cord को बाहर निकाल रहा हूँ, either there can be a prolapse of cord, or either along with the cord, along with the placenta, the uterus will also come down. It's called as uterine inversion. So in order to decrease such complications, I'm following AMTSL. If the question will be, which of the following is the best method to prevent postpartum hemorrhage, always remember your answer should be AMTSL. ठीक है ना? What is the best method to prevent postpartum hemorrhage? It's AMTSL, active management of third stage of labor. Okay. Now this complication is happening. Now the patient bleeding. Now in terms of a normal vaginal delivery, how do you define this postpartum hemorrhage? So that is defined as blood loss in normal vaginal delivery. Blood loss more than 500 ml in normal vaginal delivery. Blood loss more than 500 ml in normal vaginal delivery, or blood loss more than 1000 ml in case of cesarean section. Blood loss more than 1000 ml in case of cesarean section. Is that clear? Now mild, moderate and severe PPH. Depending upon the amount of blood, guys, we can discuss mild, moderate and severe. Mild PPH is more than 500 ml till 1000 ml. We have moderate PPH, it's more than 1000 ml. We have severe PPH which is more than 2000 ml. Okay, so more than 500 ml, more than 1000 and more than 2000 depending upon the blood loss. Okay, now if the blood loss exceeds more than 1500 ml, okay, we call it as massive obstetric hemorrhage. We call it as massive obstetric hemorrhage. Now what exactly is the term massive obstetric hemorrhage, my dear students? Any bleeding related to the pregnancy, I will call it as obstetric hemorrhage, right? Now this bleeding related to the pregnancy, either it can be before the delivery of the baby or either it can be after the delivery of the baby. When I'm talking about before the delivery of the baby, so it can be either antepartum hemorrhage, ये क्या हो सकता है सर? या तो ये antepartum hemorrhage हो सकता है सर, either it can be a postpartum hemorrhage. So what was antepartum hemorrhage? Antepartum hemorrhage is before the delivery. What is the time period you will include? Sir, it is 28 weeks onwards till the delivery. That is an antepartum hemorrhage. So what is postpartum hemorrhage? Sir, postpartum hemorrhage is after the delivery till the 12 weeks. After the delivery till the 12 weeks. Now any of the following, if the blood loss in the pregnancy if the blood loss in this hemorrhage is exceeding more than 1500 ml, at that time I call it as, I call it as massive obstetric hemorrhage. I call it as massive obstetric hemorrhage. Is that clear? So antepartum hemorrhage, if they ask what is the time, sir, it is 28 weeks onwards. Now what can be the reason for this antepartum hemorrhage? It can be the placental causes like placenta previa, vasa previa, abruptio placenta, or it can be a local causes like fibroid, polyps and all, and time should be 28 weeks till the delivery. And after that, if the bleeding occurs, then the classical answer goes to the postpartum hemorrhage. Till how long? Till 12 weeks. Till how long? Till 12 weeks. Is that clear? Is that clear? Now what are the causes of this postpartum hemorrhage? Now if we talk about the causes of postpartum hemorrhage, we have 4 T's. How many T's we have? 4 T's. So what are the 4 T's? First T, we have tone. First T, we have decreased tone, T for tone. 1 T, we have trauma. Then we have thrombin deficiency. 1 T, we have tissues. 1 T, we have tissues. So we have tone, trauma, thrombin deficiency and tissues. We have tone, trauma, thrombin deficiency and tissues. Is that clear? Now let's discuss one by one what exactly is tone, trauma, thrombin deficiency and tissues, how exactly they proceed to the postpartum hemorrhage. How exactly they proceed to the postpartum hemorrhage. Now talking about the tone. Now atonic uterus. Sir, what does atonic uterus mean? When the tone of the uterus is decreased. When the tone of the uterus is decreased. And when the tone of the uterus is decreased, the reason is over distension of the uterus. So what is the reason? So reason is over distension. Reason is over distension of the uterus. So what does over distension of the uterus means? That means the uterus is large, uterus is big, it means the large uterus. Okay, now what are the conditions the patient will have a large uterus? Kab hoga? First of all, the patient is having a twin pregnancy. So patient is having a twin pregnancy. So patient is having excessive amniotic fluid with the index of more than 25, that is polyhydramnios. So patient, the baby is having a weight more than 4 kg. We call it as macrosomic baby. We call it as macrosomic baby, and it's a classically seen with the gestational diabetes mellitus, or a baby or a mother having infection. Which infection? Chorioamnionitis. Chorioamnionitis, or the chorioamnionitis. Is that clear? These are all the causes of an atonic uterus. You get all the causes of an atonic uterus. Is that clear? So we have twin pregnancy. Okay, we have twin pregnancy, we have polyhydramnios, we have macrosomic baby more than 4 kg, and we have chorioamnionitis. All these things will cause the over distension of the uterus. When the uterus will be big, the tone will be decreased. That tone is a cause of postpartum hemorrhage. That's why the first step of this active management of third stage of labor is a uterotonic agent. It's the administration of the uterotonic agent, oxytocin, so that the tone will be maintained, patient will not have a hemorrhage. Okay, followed by that thrombin deficiency. Okay, thrombin deficiency, clotting factor related problem. Okay, तो क्या क्या हो सकता है इसमें? Patient can have idiopathic thrombocytic purpura. Patient can have idiopathic thrombocytic purpura. Followed by that, patient can have von Willebrand's disease, or patient can have hemophilia. Rarely hemophilia hota hai. Okay, patient can have hemophilia. From your hematology, please do remember what are the factors deficient. And VWD में factor 8 is deficient. Desmopressin is a drug of choice. Hemophilia A, B, C, factor 9, factor 10, factor 8, factor 9, factor 11. Is that clear? A, B, C, 8, 9, 11. Parahemophilia is factor 5. Is that clear? So anything related to the factors can also cause the bleeding. Okay, जब cesarean cut मार दिया, clotting factor ही नहीं है तो patient will start bleeding. Okay, चलो, these causes are rarely hemophilia. Okay, that's why we also give in a treatment fresh frozen plasma in case if there is a thrombin deficiency. Okay, now trauma. When can the trauma happen? For example, the opening is not enough. Okay, and there is an obstruction, and when we are using during the obstruction, when we are using the forceps, they can cause the lacerations over the cervix. Okay, they can cause the lacerations over there, and those lacerations can predispose to the bleeding, and which will cause the traumatic cause of a postpartum hemorrhage. Or sometimes the rupture can also occur, or the perineal tear can also happen, or patient can have a hematomas there. So these all are the causes for traumatic postpartum hemorrhage. Okay, they can cause the trauma. Okay, followed by that tissues. Sometimes what happen, the retained placental tissues remain inside only. So after the delivery, some small bits of the placenta, they remain inside, and after 24 hours, after 1 day, after 2 days, patient will complaining of bleeding due to these retained products of conception, due to these retained tissues, retained placental tissues, bits of tissues. That is a predisposed to the bleeding with the cause of a tissue. So what is tissues? So due to retained placental beds, so they will cause bleeding usually after 24 hours, which is called as secondary postpartum hemorrhage. So what are the 4 T's? Sir, atonic uterus, trauma, tissues, and thrombin deficiency. Now based upon the timing, we have a types of postpartum hemorrhage. So either we will have a primary postpartum hemorrhage, or either we'll have a secondary postpartum hemorrhage. Now what is primary postpartum hemorrhage? So primary postpartum hemorrhage means which occurs within 24 hours. So it's a bleeding which occurs within 24 hours, and the most common cause is atonic uterus. And the most common cause is atonic uterus. Is that clear? So the most common cause for primary PPH is atonic uterus. Okay, now what is secondary postpartum hemorrhage? So secondary postpartum hemorrhage is which occurs after 24 hours. It is which occurs after 24 hours. And after 24 hours, the most common cause, what is the most common cause after 24 hours? It is retained placental bits or retained tissues. That it is retained tissues. Is that clear? So we have primary PPH and we have secondary postpartum hemorrhage. So what is primary PPH? If the bleeding occurs within 24 hours. And what is secondary PPH? If the bleeding occurs after 24 hours. Now if the question is like most common cause for primary PPH is, what will be your answer for the most common cause for the primary PPH? So the answer goes with the atonic uterus. That means the tone is decreased, there is an over distension of the uterus. So what is the cause after 24 hours? That cause can be retained tissues or retained placental beds. Okay, now how to differentiate whether the PPH is atonic PPH or a traumatic PPH? Okay, how to differentiate? We go for a per abdominal examination. Okay, we go for a per abdominal examination, and on per abdominal examination, sir, if a patient on per abdominal examination, if a patient is having palpable uterus is palpable, sir, the answer goes with a traumatic PPH. So the answer goes with the traumatic PPH. Okay, so after per abdominal examination, if a patient is having non-palpable uterus, so you'll write just uterus not palpable. Uterus not palpable, the answer goes to atonic PPH. Answer goes to atonic PPH. Is that clear? So how to differentiate? So per abdominal examination, and after per abdominal examination we'll check if the uterus is palpable, it is going to be a traumatic PPH. If the uterus is not palpable, it's going to be a atonic PPH. It's going to be atonic PPH. Okay, now what will be the medical management? Now first of all, we'll start the prophylactic drug. What is a prophylactic drug we'll start in order to prevent? So we are starting oxytocin. And how much of oxytocin will start in the prophylaxis? So 5 to 10 units. And this 5 to 10 units you will give just after the delivery of the shoulder. Okay, just after the delivery of the shoulder, give a prophylactic drug oxytocin, which will maintain the tone of the uterus. And what will be the dosage of the drug? 5 to 10 units after delivery of shoulder. After delivery of shoulder. Okay, followed by that, if a patient is having now a postpartum hemorrhage, now if it is a case of a postpartum hemorrhage, again as a treatment, drug of choice for postpartum hemorrhage. Okay, again the drug that you start is oxytocin. Now again the drug that you are giving is oxytocin, but this time the dose of the oxytocin you have to start with 10 to 20 international units in 500 ml of NS, or you will write in drip form. Okay, in 500 ml of NS. Make sure you are giving this in 500 ml of NS. Never give bolus. Okay, no bolus if you are giving bolus, because the patient will have a complication after giving a IV bolus oxytocin, and this has been the question asked. The answer is it can cause sudden hypotension, or it can cause cardiac arrest, Is that clear? Remember, never give bolus oxytocin. This is a PYQ. Never give bolus oxytocin. What will be the complication, bache? So the complication will be it can cause sudden hypotension or cardiac arrest. Okay, the first drug is oxytocin. Followed by that, we can use the second drug called as methyl ergometrin or methergin. We can use methyl ergometrin. Okay, how much to use? So we can give 0.2 mg intramuscular injection. Okay, and this drug has a peak action in 90 seconds, but the question that they can ask from this particular drug is the contraindication. So what is the contraindication of this drug? This is the question that they can ask. First of all, never give in hypertension. Okay, you cannot give this drug in hypertension. Number first contraindication is hypertension. Number second is heart disease. You cannot give this drug in a patient having a heart disease. Usually pregnancy, most commonly we having rheumatic heart disease, and the question can mention that the patient has a RHD with the active lesion of a mitral stenosis. Which of the following PPH drug is contraindicated, or which of the following drug is contraindicated? Your answer goes to methergin or methyl ergometrin. Okay, patient with RH isoimmunization or RH incompatibility, RH negative pregnancy. Again, the drug is contraindicated, or before the delivery of second twin, or before the delivery of second twin. Is that clear? So these are the contraindications. These are the contraindications of a drug methyl ergometrin. Methyl ergometrin. Followed by that, we can also use misoprostol. Then write the other drugs. So we can use misoprostol. Misoprostol is prostaglandin E1. So we can use injection carboprost. It is PGF2 alpha. So we can also use injection tranexamic acid. Injection tranexamic acid. We can use 1 gram in 100 ml of NS. Okay, it will also stop bleeding. Whenever patient is having active bleeding, we always give tranexamine. So we can also use injection tranexamic acid 1 gram. We can also use fresh frozen plasma. We can also use fresh frozen plasma. Okay, now my dear student, these all drugs that I have mentioned are the medical management. Okay, now the question that I have asked, this injection carboprost, it can be given 0.25 mg, and maximum dosage it can be given is 8 doses, 2 mg. This is the question that I have asked, injection carboprost. Number first thing, can you tell me what is the side effect, what is the contraindication of a drug carboprost? Can you tell me what is the contraindication of a drug carboprost? What is the contraindication of a drug carboprost? What is the contraindication of a drug carboprost? Yes, carboprost is not used. The contraindication for the carboprost is, write down here, carboprost contraindicated in asthma. Carboprost, it's contraindicated in asthma. And one more thing, the carboprost is a drug of choice when the PPH is resistant to all routine drugs. Sir, what does that mean? If oxytocin and methyl ergometrin is not working, go with the carboprost. That's why it's a most potent drug. It's a most potent drug. Is that clear? Is that clear? Yes, is that clear to everyone? Most potent drug of PPH or resistant to routine drugs, the drug is carboprost. The drug is carboprost, PGF2 alpha. Now, if the medical management is failed, now patient is bleeding, patient is bleeding, you gave Tranexa, you gave misoprostol, oxytocin and all. Now, if the medical management is failed, we go with a mechanical compression. We use a balloon tamponades and they will do a mechanical compression. Okay, they will do a mechanical compression, and this mechanical compression we are doing with the help of a balloon tamponades. And in balloon tamponades, what are we using? This one, the picture, it is a Buckley's balloon. क्या बोलते हैं इसको बच्चे? Sir, this is called as Buckley's balloon, and the capacity of Buckley balloon is 500 ml. It is 500 ml. Is that clear? And we are placing this Buckley balloon, inflate it with a normal saline 500 ml. The pressure over the walls will stop the bleeding. Okay, and make sure that if the bleeding stop, okay, after bleeding stops, remove, write like this, remove after 12 hours, remove after 12 hours, when bleeding is stopped, remove after 12 hours. Is that clear? Yes. Now what a mechanical compression we are using? Buckley's balloon. Sir, for mechanical compression we are also using Foley's catheter. Sir, for mechanical compression we are also using Sengstaken tubes. But in India we are cheaper, we use condoms. Okay, so that's all about the mechanical compression. Okay, now if the mechanical compression is failed, we'll use the compression sutures. Followed by that, sir, we are using compression sutures. Now what are the compression sutures we are using? We need to compress the uterus. We are using a most common type of suture. We are using a B-Lynch suture. Now bache, if this is the uterus over here, okay, if this is the uterus over here, and now I'm using the suture, okay, anteriorly and posteriorly, like here I'm using this suture like here, okay, so that anterior and posterior side will meet at one place. This sutures is called as compression sutures, and compression suture most commonly we use a B-Lynch suture. Sometimes the multiple times will put the suture over the uterus. That suture is called as Heyman suture. Okay, this is the B-Lynch most one. So we also use Heyman suture. We also use square suture, or we also use gun shell suture. Okay, these are all the compression sutures that we use in order to stop the bleeding. So first AMTSL, then medical management, then mechanical compression, then surgical compression. Okay, if bleeding is still not stopped, we go for the artery ligation. If bleeding is not stopped, we go for the artery ligation. Now the question was asked, what is the order of the arteries ligated? You have to remember these arteries in order. So number first, sir, is uterine artery. Number second is ovarian artery. And followed by that we have internal iliac artery. Okay, now my dear students, if we talk about the internal iliac artery, we have two branches, anterior branch and a posterior branch. Okay, the posterior goes to the lower limbs, and if a patient is having a postpartum hemorrhage and the doctor misidentified the artery and ligated the posterior internal iliac artery, so what will be the complication patient will have? Patient will complain of a numbness. Okay, patient will complain of a paralysis and all due to the ligation of a posterior internal iliac artery. So remember, in a question they will mention which branch of internal iliac artery you have to ligate. Sir, anterior branch of internal iliac artery. Okay, don't ligate posterior one. Remember bache, don't ligate posterior one. Okay, remember for the posterior one. Okay, remember posterior internal iliac artery. Okay, we have three branches. Remember, whenever the question will be which of the following branch should not be ligated in case of a PPH, remember these three branches. We have superior gluteal, we have iliolumbar, and we have lateral sacral. Okay, never ligate these branches. Okay, never ligate these branches. If we ligate these branches, patient will complain of paralysis and numbness. Okay, always ligate anterior branch of internal iliac artery. So if the bleeding is still not stopped, we'll go with a supracervical or subtotal hysterectomy. We'll go with the subtotal hysterectomy. Subtotal hysterectomy will only remove the uterus, not the cervix. And if the bleeding is still not stopped, we'll go with total abdominal hysterectomy. Is that clear? That is all about postpartum hemorrhage. Okay, what is total abdominal hysterectomy? Uterus plus cervix. What is subtotal? Only uterus, not cervix. So this is the stepwise treatment for the postpartum hemorrhage. Now my dear students, answer me fast. So first of all, what is postpartum hemorrhage? Sir, postpartum hemorrhage is bleeding after the delivery. So it is usually the complication of which stage of labor? Third stage of labor. What is exactly the third stage of labor? So third stage of labor means delivery of the baby to the delivery of the placenta. Usually this third stage lasts 10 to 15 minutes. Okay, but if it's go beyond 30 minutes, we call it as prolonged third stage of labor. Okay, that is coming up. Now after that, sir, In normal vaginal delivery, the blood loss is more than 500 ml. In cesarean section, the blood loss is more than 1000 ml. Okay, after this we discuss about the causes of this postpartum hemorrhage. We have 4 T's. We have tone, we have tissue, we have trauma, and we have thrombin deficiency. So what is tone? Tone is when the tone is what is tone? Tone is due to the over distension of the uterus. Due to the large uterus, the tone of the uterus is decreased, and due to the decreased tone of the uterus, the chances of an PPH are more. What are the conditions the tone are decreased? Due to the over distension, like polyhydramnios, like macrosomic baby, like the infection chorioamnionitis, or like the twin pregnancy or the triplets. Okay, followed by that, if patient is having a lacerations, perineal tear, or hematomas, that will predispose to the traumatic cause of the postpartum hemorrhage. If there are retained placental bits, that will also cause a postpartum hemorrhage. Or if there is something wrong with the clotting factors, thrombin deficiency, that will also cause a postpartum hemorrhage. Okay, now types of postpartum hemorrhage, we have 2 types. What are the 2 types? The primary and secondary. Question was asked, which of the following is the most common cause of secondary postpartum hemorrhage? Never write atonic uterus always. Atonic is for a primary PPH. Atonic is most common cause for primary PPH. Okay, for secondary postpartum hemorrhage, what will be the cause? Secondary postpartum hemorrhage mein retained placental beds. What is the cause? Retained placental beds. Okay, now what will be the treatment for the retained placental beds, and what will be the complication? Anyone in the comment section? So what will be the treatment for a retained placental beds? If the retained tissues are there, if the volume is less, retained products of conception are less, we go with the medical drugs. Yes, but if the volume is more, we go with the curate. When we go for the curettage, बच्चे, the scarring over there, the scar formation over there, वहाँ पे additions बनते हैं, and those additions, the Seineke formations, this name, classical name of a syndrome. What is the name of the syndrome? Due to the over curettage, there is a scar formation over there, which further lead to the additions, and this complication is usually due to the over curate. Okay, and the syndrome is called as, what is the name of the syndrome, bachche? Anyone in the comment section? What is the name of the syndrome? The name of the syndrome is Asherman syndrome, also called as uterine Seineke. Okay, and when these additions are over there, you need to cut down these additions. So what will be the treatment? So we go for the hysteroscopic adhesiolysis. क्या करेंगे treatment में? We go for the hysteroscopic adhesiolysis. We go for the hysteroscopic adhesiolysis. Okay, followed by that, how to differentiate between the atonic and the traumatic PPH. Atonic में क्या होता है? So atonic में traumatic PPH. So atonic में क्या होता है? Uterus is not palpable. In traumatic, uterus is palpable. Okay, medical management, the prophylactic drug that we are going to start is an oxytocin. How much of oxytocin so we are giving? We are giving oxytocin 5 to 10 units. Okay, and after the delivery of the shoulders, as per the AMDSL. And drug of choice, if the treatment of postpartum hemorrhage is to be asked, that drug of choice again is going to be oxytocin. How much? Sir, 10 to 20 international units. 10 to 20 international units in a 500 ml of NS. How much? In 500 ml of NS. Okay, no bolus. If we give bolus, it will cause sudden hypotension or cardiac arrest. That's why always advised to give this in a drip form. Okay, the second drug, we can also use methyl ergometrin 0.2 mg intramuscular, but the contraindications of this drug, remember, so it's not given in the patient having a hypertension, not given the patient having a heart disease. RHD will be the hint, mitral stenosis will be the hint. Don't use methyl ergometrin. Important question. RH negative pregnancy or before the delivery of second twin. Okay, followed by that, we can use mesoprostol 1000 micrograms, है ना, we can give rectally, vaginally, है ना, ठीक है. Followed by that, injection carboprost PGF2 alpha, maximum dose of 2 mg. 8 doses you can give with the single dose of 0.25 mg. Okay, we can use tranexamic acid, okay, 1 gram in 100 ml of NS as well to stop the bleeding. Or followed by that, if there is a thrombin deficiency, we can use fresh frozen plasma. Remember the contraindication of the carboprost, it is asthma. Okay, then balloon tamponades, we can use a mechanical compression with the help of a tamponades. What are the tamponades? Buckley's balloon, Foley's catheter, Sanger-Steken tube, and the condoms. We have compression sutures. We have Beeline suture, Heyman suture, and the co-square suture. The most common one is the Beeline suture. Is that clear? And make sure that once the bleeding is stopped, the Buckley balloon is removed after 12 hours. It's removed after 12 hours. Then if the bleeding is still not stopped, we go for the artery ligation. What is the artery ligated? So we ligate the stepwise. First we ligate the uterine artery, then we ligate the ovarian artery, and then internal iliac artery. Make sure which branch of internal iliac artery will ligate. The anterior branch of internal iliac artery. The anterior branch of internal iliac artery. Okay. Make sure that you will not ligate the posterior one. What are the branches? Superior gluteal, iliolumbar, and lateral sacral. Okay, and if the bleeding is not stopped, subtotal, and then remove the uterus plus cervix, called as total hysterectomy. Total abdominal hysterectomy. Okay, is that clear to everyone? Is that clear to everyone? Yes, PPH is clear to everyone. Let's move to the next question and the topic now. A 28-year-old woman present to the labor ward in an active labor. She delivers a healthy baby vaginally. During the delivery of the placenta, there is a sudden onset of profuse vaginal bleeding and the severe lower abdominal pain. The attending physician notes that the uterine fundus is not palpable. The uterine fundus is not palpable abdominally. On inspection, a fleshy mass is seen protruding from the vagina. Okay, what is the most likely diagnosis? What is the most likely diagnosis? So you have a mother over there, 28-year-old. She's present in the labor ward and she's in the active labor. Okay, she's in the active labor. Then latent phase, active phase of labor, I've already discussed. Now she delivers a baby. Okay, during the delivery of the placenta, you are seeing the sudden onset of bleeding, rush of blood. Okay, there is rush of blood, and that's why it's mentioned that whenever a patient is going immediately into the shock after the delivery, you are suspecting one condition, that is a uterine inversion. Okay, now after that, there is a severe lower abdominal pain. The fundus is not palpable, and or are seeing on inspection something is coming out of vagina. Now if there is a cup-like depression on the fundus, that means something is missing there. What is missing? Uterus. और वो uterus कहाँ पे आया? That is seen protruding outside. This is the classical picture. Okay, now this picture is given over there, and what is your likely diagnosis? What is your likely diagnosis? Now what is the likely diagnosis, guys? So it's a case of a uterine inversion. This is a case of a uterine inversion. Now my dear students, when we talk about this uterine inversion, what is coming out? Uterus is coming out. But in case of a uterine prolapse, also what is coming out in prolapse? Sir, prolapse में भी uterus बाहर आ रहा है. ठीक है? So what exactly is the difference? If both the condition, uterus is protruding out. In case of a uterine inversion, there is turning upside down of the uterus. Okay, there is upside down of the uterus, but when we define the uterine prolapse, there is descending down of the uterus. Okay, it can be due to the connective tissue disorder, it can be due to the mismanaged third stage of labor, it can be due to the increased abdominal pressure. Okay, all these things can lead to the uterine prolapse, usually seen in the elderly woman. Yes or no? Ligament of the uterus are weak, support of the uterus is weak, pelvic floor muscles are weak. That's why the prolapse is taking place. But usually in case of an uterine inversion, what is happening? Turning upside down of the uterus. अगर बच्चे uterus इस तरह का है, okay, uterus is like this, so uterus is coming out like this. Okay, these things are intact, sorry. Okay, ये सब intact है, but just up and down होता है. So once there is up and down of the uterus, turning upside down of the uterus, the condition is called as uterine prolapse. The condition is called as uterine inversion. Now my dear students, let's discuss what exactly is uterine inversion, what are the clinical features of uterine inversion, and what are the causes of uterine inversion, and what exactly is the treatment for this particular condition. Okay, now you have seen it's already given over there that there is profuse vaginal bleeding. So whenever a question will mention that a patient is going immediately into the shock, whenever a question mentions after delivery, patient goes immediately into the shock. Okay, immediately into the shock, you are suspecting, sir, this can be the case of uterine inversion. My dear students, postpartum hemorrhage patient eventually goes into the shock as well, but if it's immediate, if it's fast, then your diagnosis goes to the uterine inversion. So diagnosis kya? Uterine inversion. And if the question mentions immediately, uterine inversion. If a question mentions probable, generally goes into the shock, PPH. Okay, if question mentions unexplained shock with the hypotension, hypoxia and coagulopathy, okay, that means something from the amniotic fluid contents is going into the maternal circulation, and pregnancy is a hypocoagulable state. So that condition is called as amniotic fluid embolism. Okay, I will come to that as well, but here let's clear it down. What is uterine inversion? Okay, now if we define this uterine inversion, simple words, so it is prolapse of the fundus of uterus. So it's prolapse of fundus of uterus, prolapse of fundus of uterus into uterine cavity. okay, into uterine cavity. This is called as uterine inversion. तो क्या बोलेंगे इसको बच्चे? So it's called as uterine inversion. Now what can be the possible causes of this uterine inversion? Okay, if we talk about the etiology, of this uterine inversion, most common cause, as I've already told you, postpartum hemorrhage, uterine inversion, shock, these are all the complications of which stage of labor, bache? Third stage of labor. That's why there was AMTSL in order to prevent such complication. So the most common cause for uterine inversion is mismanaged third stage of labor. So that is mismanaged third stage of labor. That is mismanaged third stage of labor. Okay, what can be the other causes? It can be badly adherent placenta. It can be badly adherent placenta. Okay, now so what exactly is a badly adherent placenta? Okay, now if this is the uterus, okay, this is the placenta attached over here. Here we have a classical layer, fibrinoid layer called as neta bush layer. Okay, neta bush layer. Okay, and if this neta bush layer is absent, this placenta starts invading inside. Okay, it's attached to the myometrium, then it's invading the myometrium, and then it can go up to the pelvic structures like bladder. So when the neta bush layer is absent, when there is a defect in the neta bush layer, or there is an absence of a decidua basalis, okay, so the syndrome or the types of placenta is called as placenta accreta spectrum, or it's called as adherent placenta. Now depending upon the invasion of this placenta, we have a different types of adherent placentas. If it is attached to myometrium, okay, we have accreta. If it is invading the myometrium, we have increta. If it is going through pelvic structures, it is parcreta. So accreta, increta and parcreta are the three morbidly adherent placentas. So do you understand how and what are the types of an adherent placenta? I will again say, sir, what is adherent placenta? When the neta bush layer is absent, this placenta is invading the myometrium, attaching the myometrium, or going to the pelvic structures. Such type of placentas are called as adherent placenta, depending upon the degree, accreta, increta and parcreta. And when I try to remove this placenta, which is badly adherent, if this is the uterus again, bache, and this is the placenta, now this placenta is invading this much into the uterine muscle, and when I try to take out this placenta, along with the placenta, what is coming out? Uterus is coming out. That's what you call uterine inversion due to badly adherent placenta. This can be also the cause of uterine inversion. One more cause of the uterine inversion can also be there, that is sudden cord traction. Okay, one more cause can also be there, which is sudden cord traction. So sudden cord traction also causes uterine inversion. Sudden cord traction also causes uterine inversion or uterine atony. These are all the causes of the uterine inversion. They are all the causes of the uterine inversion. Okay, now when a patient, you are seeing the patient and going for the per abdominal examination. So when you are going on the per abdominal examination, you will see fundus is not palpated. That means fundus is depressed. Kya likhoge? So on per abdominal examination, fundus is depressed, or there is cup-like depression. Why? Because sir, the uterus that you are trying to find over the fundus, that is outside. That's why on per vaginal examination, you are seeing there is mass in vagina. There is mass in vagina. You are seeing that this mass is coming out, this mass is protruding out. This is a uterine inversion. So when a finding is given, immediately into the shock, abdomen is on abdominal examination, fundus is depressed, cup-like depression is seen. On per vaginal examination, bleeding and mass is coming out, suspect that it's a case of a uterine inversion. Remember, my dear students, patient first goes into the neurogenic shock, okay, followed by hemorrhagic shock. And remember, the most common cause of death will be hemorrhagic shock. the most common cause of death will be hemorrhagic shock. Is that clear? The most common cause of death will be hemorrhagic shock. That's about uterine inversion. That's about uterine inversion. Is that clear? Is that clear? Now what will be the management? Now, as I've already said, that this case a patient is having, in this case the patient is having immediately, a patient is having a heavy bleeding and immediately goes into the shock. The first management always will be first, sir, resuscitation. So for the uterine inversion, first I'm going for resuscitation and call for help. Call for help. Okay, followed by that you need to try and repose it. You need to try and repose it, the uterus, as soon as possible. Now what you will do, bache, you will take the uterus, it's outside, okay, take the uterus, okay, push it in, and with the fist take back it to the normal position. Okay, and this manual reposition of the uterus, write down in the comment section, this manual reposition of the uterus is called as, so we call it as Johnson's maneuver. Kya bolte hai isko bache? So we call this as Johnson's maneuver. Okay, so remember, in Johnson's maneuver the part which comes down the first, जो पहले आया वो सबसे last में जाएगा. Okay, so part which comes down first, the part which comes down first will go last. Will go last. This is Johnson's maneuver. Question was asked, case of a uterine inversion, what's your first step? A resuscitation was not given in an option. Your answer goes to Johnson's maneuver. Your answer goes to Johnson's maneuver. We have one outdated method as well. यहाँ पे क्या करेंगे? Use manual reposition. Write it down. So we are going for a manual reposition, which is called as Johnson's maneuver. Which is called as Johnson's maneuver. Okay, followed by that, my dear students, we have one more outdated method. हमारे पास और एक outdated method है, that is called as hydrostatic method. Hydrostatic method called as O'Sullivan method. Called as O'Sullivan method. Is that clear? Is that clear? Yes, sir. After that, to relax the uterus, give a drugs like terbutaline and nitroglycerin. Okay, and then repose it. Once you put it back, give oxytocin and methogen so that bleeding nahi hoga, so that you stop the bleeding. Oxytocin and methogen. Okay, make sure guys you will remove the placenta after, once you make the uterus relax after giving the drugs. Okay, पहले back करो, relax करो drugs के साथ, then remove the placenta. Okay, if placenta is attached. Okay, some say remove the placenta prior, some says remove the placenta after, but yes, you need to relax the uterus first. So relax with the help of drugs first. So पहले relax करके terbutaline देके, then we can remove the placenta. Okay, after that, okay, if these failed procedures, if Johnson's maneuver is failed, relax the uterus, then repose it. If again that is failed after giving oxytocin and methogen and terbutaline, we can go for the surgical procedures. And what are the surgical procedures? We have Huntington and Haltian procedure. The name of the procedure we have, sir, Huntington and Haltian procedure. Name of the procedure we have Huntington and Haltian procedure. Is that clear? That is all about the uterine inversion. That is all about the uterine inversion. Is that clear? Yes. Okay, so patient had profuse vaginal bleeding along with abdominal pain. Fundus was not palpable, something fleshy was coming out. You are suspecting that this is a case of uterine inversion. Okay, this is a case of uterine inversion. Uterine rupture में क्या होगा? Abdominal baby fetal parts are palpable. Okay, patient will have a pain, abdomen, bleeding per vagina, but one more finding will be palpable parts. Okay, retained placenta is something that when a placenta is not delivered after 30 minutes, of a third stage of labor. So usually third stage of labor lasts 10 to 15 minutes, but when it exceeds more than 30 minutes, okay, it is called as prolonged third stage of labor or retained placenta. Okay, abruption is something I will discuss in the part 2. What exactly is abruption? That there is premature separation of a normally implanted placenta with the features of pain abdomen, bleeding vaginally along with a tender and rigid uterus. Okay, that is something antepartum hemorrhage cause abruption that we'll discuss in the part 2. So this is a classical case of uterine inversion. Okay, do remember guys, cup-like depression, and do remember these findings so that you will land in an exact diagnosis. Okay, next one, what is the most common ovarian tumor? What is the most common ovarian tumor to have pseudomyxoma peritoni? What is the most common ovarian tumor to have pseudomyxoma peritoni? Yes, bache, answer this. What is the most common ovarian tumor to have pseudomyxoma peritoni? Excess mucin. Okay, we have discussed what are the epithelial tumors, what are the sex cord tumors, and what are the germ cell tumors. Okay, then in the epithelial tumors we have discussed, we have serous cystadenoma, mucinous cystadenoma, we have Brenner tumor, and we have endometrioid tumor, hai na? So tell me, which of the following ovarian tumor is associated or having pseudomyxoma peritoni or peritoni? Chalo, bata do sir, which one it is? Option A, mucinous cyst adenoma. What is the answer? Option A, mucinous cyst adenoma. Okay, now let's discuss about the ovarian tumors. One of the findings, main findings of these ovarian tumors, and you will write and remember these findings. What exactly are these findings, bache? Okay, so about the ovarian tumors, first one, serous cyst adenoma. So serous cyst adenoma is a type of an epithelial ovarian tumor in which, yes, A is the correct answer. Serous cyst adenoma is a type of a epithelial tumor in which we have bodies called as samoma bodies. So usually, my dear students, we write ovarian tumor as having a samoma body, but which ovarian tumor? That is a serous cyst adenoma. And now this samoma body is kind of sarkari body that everyone knows that it is also seen in papillary thyroid carcinoma along with the orphanania nuclei. It's also seen with the meningioma. It's also seen with the mesothelioma. It's also seen with the serous cyst adenoma. Okay, you also seen with meningioma. Okay, meningioma, M is 2, like mesothelioma and meningioma, papillary thyroid carcinoma, hai na? Okay, you already know about this serous cyst adenoma. These are calcium centered bodies made up of calcium. Okay, it is calcium. Okay, so serous cyst adenoma. Then mucinous cyst adenoma. What is mucinous cyst adenoma? Mucinous cyst adenoma. In mucinous cyst adenoma, you'll remember that there is pseudomyxoma peritoni, excess mucin. Pseudomyxoma peritoni. Okay, then we have a Brenner tumor which is associated with the pseudomag syndrome, Okay, now what exactly is pseudomag syndrome? So three things in pseudomag syndrome. We have Brenner tumor, pleural effusion, and ascites. क्या क्या हमारे पास? So we have Brenner tumor, we have pleural effusion, and we have ascites. Okay, in Meg syndrome we have fibroma ovary. In Meg syndrome, remember, fibroma ovary. Along with that, again the two same things, we have pleural effusion and we have ascites. If we talk about a teratoma, guys, it's also called as benign dermoid cyst. Okay, 90% of them are benign and 10% are malignant. This is a tumor which is made up of all three layers, ectoderm, endoderm, and mesoderm, and it's a most common tumor of the pregnancy, and it's a most common tumor which undergoes a torsion. And one more classical feature, that if the picture of the tumor is given, it will be given that there is a teeth and hair like structures inside the tumor with young age group. Okay, so teratoma, right, all three layers are present. First of all, right, it's a type of a germ cell tumor. It's a germ cell tumor. So all three layers. What are the three layers? We have ecto, endo, and meso. Ecto, endo, and mesoderm. Okay, followed by that, the most common tumor of pregnancy, or the most common tumor which undergoes a torsion, again your answer goes with teratoma. Again your answer goes with teratoma. Again your answer goes with teratoma. Okay, then we have dysgerminoma. Okay, there are increased levels of LDH, okay, and increased levels of placental alkaline phosphate. Placental alkaline phosphate. Okay, we have yolk sac tumor, my dear students, associated with increased alpha fetoprotein. Okay, it's having increased alpha 1 antitrypsin. Okay, if decrease given, pan acinar emphysema. Remember that, at least this hint. Okay, on the classical bodies which are seen in case of a yolk sac tumor are Schiller dual bodies. We have Schiller dual bodies. Okay, then we have a granulosa cell tumor. Okay, classical bodies, Carl Exner bodies. They are rosette shaped bodies. Okay, same like the bodies which are seen in the retinoblastoma, flexner interstitial rosettes. Okay, same like that. Okay, and these Carl Exner bodies are seen in GCT, which is an estrogen secreting tumor, as discussed already, and the marker for this particular tumor is inhibin. Okay, is inhibin. Is that clear? Is that clear to everyone? Okay, we have one more ovarian tumor which is a secondary to the ovaries, which is metastasized from the cancer stomach or the breast cancer. The tumor is called as Krukenberg's tumor. The tumor is called as Krukenberg tumor. The tumor is called as Krukenberg tumor. Okay, usually coming from secondary to ovaries, and it usually most commonly coming from the cancer stomach followed by breast cancer. And और इसमें क्या signet ring cells, just right, signet ring cells, stomach से आता है and breast. Okay, so this is all about the ovarian tumors. It's all about the ovarian tumors. Is that clear? Is that clear to everyone? Yes, write down in the comment section, bache. Is that clear to everyone? Followed by that, we discuss about the Asherman syndrome. Followed by this, we discuss about the Asherman syndrome. So one word about the each cancer so that you can remember in a quick manner. Agar samoma bodies are given a hint in the question, you mark the serous adenoma. If they mention there is an accessory mucin called pseudomyxoma peritonei due to the fibrosis, peritoneal fibrosis, mucinous cyst adenoma. If the pseudomyx syndrome hint is given, you mark the Brenner's tumor. If the Make syndrome, that is fibroma ovary, pleural effusion or ascites. Teratoma, it's a germ cell tumor. Okay, and it's made of all three layers, and these are the tumors which go under the torsion and the most common tumors of the pregnancy. If a patient, if it's mentioned increased LDH levels and PAP, you suspecting of dysgerminoma. Okay, if it is Schiller dual bodies or increased alpha fetoprotein or alpha 1 antitrypsin, you mark yolk sac tumor. If there are Carl Exner bodies, rosette shaped like bodies, and inhibin marker given, you mark the granulosa cell tumor. If they mention that the cancer is coming from the stomach or signet ring cells are present, or it's mentioning that it's from metastasized from the breast, then you mark the Krukenberg's tumor. Then you mark the Krukenberg's tumor. Is that clear? Yes. Now next one is Asherman syndrome. Next one is Asherman syndrome. Okay. Now what is this Asherman syndrome, guys? It is actually the complication of curettage. Okay, so whenever we have a retained placenta or whenever we have retained placental beds, if the volume is too much, we go for the curettage, and that curettage can lead to the Synike formation. Okay, so that further lead to the adhesions. Okay, on the investigations you will see there is a filling defect over here, and here it's a normal uterus, but in case of an Asherman syndrome, over scarring की वजह से यहाँ पे क्या बने adhesions. So the treatment for that particular condition is adhesiolysis. ठीक है ना? So let's write it in a very concise way. Sir, it is also known as. Sir, it is also known as. So Asherman syndrome is also known as, there is a Synike formation. That's why it's also called as uterine Synike. It's also called as uterine Synike. Okay, let me write it clearly. It's also called as uterine Synike. Okay, followed by that, sir, it is characterized by It's characterized by formation of scar tissue. It's characterized by formation of scar tissue. Okay, and over there adhesions, scar tissue or adhesions within the uterine cavity, within uterine cavity. So within the uterine cavity we have a scarring or adhesions. Okay, followed by that, what can be the causes? So what can be the causes? So the causes can be dilatation and curate and myomectomy. These are all the causes for a Asherman syndrome. And simple mein, what will be the management? Sir, you have to break these adhesions. So you will go for hysteroscopic adhesiolysis. We go for hysteroscopic adhesiolysis. We go for hysteroscopic adhesiolysis. Is that clear? Is that clear to everyone? Yes. So this is an Asherman syndrome. So even when the question will be asked from then amenorrhea, अगर secondary amenorrhea हो रहा है patient को, and after giving estrogen, and at first 3 cases of Asherman, 3 cases of secondary amenorrhea can be asked. Okay, अब patient को अगर secondary amenorrhea हो रहा है, there can be 3 possible scenarios. Okay, after secondary amenorrhea, if you are giving a progesterone and patient को bleed आया, तो it can be a PCOS. After giving estrogen and progesterone, patient bleeded, it can be a case of Sheehan syndrome. And after giving estrogen and progesterone, patient did not bleed, it is a case of an Asherman syndrome. Because in Asherman syndrome, the problem is not with the hormones. Okay, there is nothing wrong with FSH, LH, estrogen and progesterone. The problem is with the addition. So what is the treatment in order, what is will be the treatment in order to get the normal menses in case of an Asherman syndrome? Go for the hysteroscopic adhesiolysis. Okay, I will teach you tomorrow in the part 2 what exactly how to approach a secondary amenorrhea patient, how to approach the secondary amenorrhea patient. Is that clear? Yes. Let's move to the next question. Okay, few questions more and then we done for the part 1. A 25-year-old female with a history of 2 weeks amenorrhea. She came in an emergency with complaints of scanty vaginal bleeding. On examination, no adnexal mass is noted. The lab investigation HCG was 1400 units. Uterus was bulky. Trilaminar endometrium was seen. Patient vitals were stable. What is the next step to do? What will be the next step to do? Yes, my dear students, write down everyone in the comment section the answer. What will be the next step to do? What will be the next step to do? Yes. Now at 2 weeks, obviously the USG and all they won't be conclusive because it's already mentioned that no adnexal mass was noted. Okay, so sir, the best treatment here will be what? You will repeat the HCG after 48 hours. Yes or no? Yes, because at 2 weeks amenorrhea only, the investigations will be inconclusive, है ना? Yeah, ठीक है ना? Because beta HCG is already done ना. So the best part is that you repeat it after 48 hours. अगर double हो रहा है then you go with the intrauterine. अगर double नहीं हो रहा है then you go with an ectopic. अगर कम हो रहा है you go with an abortion. So with a particular case you cannot go for wait and watch. You just have to repeat it after 48 hours. Okay, then you will get to know if it is intrauterine, carry on. If it is ectopic, proceed already, and if it is abortion, go accordingly. Is that clear? So repeat HCG after 48 hours. Okay, now now let's understand. Now if we talk about the HCG doubling, अगर HCG की बात की जाए, if it is doubling in 48 hours, if it is doubling in 48 hours, sir, it is a case of intrauterine pregnancy. It is a case of intrauterine pregnancy. Okay, sir, if it is doubling in 5 to 7 days, if it is doubling in 5 to 7 days, Okay, that means if it's double by 33%, then it's a case of an ectopic pregnancy. Okay, if it is fall by 50% in 48 hours, this is a case of abortion. This is a case of abortion. So remember guys, HCG doubling in 48 hours, doubling in 5 to 7 days, fall by or decrease by 50%. This is a case of abortion. Is that clear? That's how we get to know by beta HCG. Now after that, my dear students, if we talk about double decidual sac, this is the double decidual sac. Double decidual sac. Okay, now this double decidual sac, there are two layers, inner layer and outer layer. Double decidual sac on USG. If you remember the question from an ectopic pregnancy, my dear students, I mentioned over there in a clinical case that there was no double decidual sac present. So if there is no double decidual sac present, it indicates, what does it indicate? Sir, it indicates the ectopic pregnancy. Now this double decidual sac is formed by two layers, outer layer and inner layer. So what is outer layer? Outer layer is due to the decidua paritalis. Outer layer is due to decidua paritalis, and inner layer is due to decidua capsularis. It is due to decidua capsularis. And what does it indicate? What does it indicate? It indicates the intrauterine pregnancy. It indicates the intrauterine pregnancy. Is that clear? Is that clear? Yes. So remember, double decidual sac is there. It is a intrauterine pregnancy. If it is not there, it is a intrauterine pregnancy. It is a intrauterine pregnancy. Clear to everyone? Yes. Is that clear to everyone? Yes. Okay, one more question and then we have a quick recap and end this session. A primary gravida is brought home by her relatives just after 1 hour of the vaginal delivery of a full-term healthy infant. The baby is doing well. On examination, patient is hypotensive, hypoxic and having disseminated intravascular coagulation. What is your most likely diagnosis? So this is a classical triad of a hypoxia, hypotension and coagulopathy. What will be your answer, bache? What will be your answer for this particular question? Hypoxia, hypotension and coagulopathy. What will be your answer? So answer is going to be D, amniotic fluid embolism. Amniotic fluid embolism. Okay. Now let's discuss this amniotic fluid embolism. Okay. First thing, अगर embolism से question आया और pregnant lady का history दिया हुआ है, what are you expecting? Amniotic fluid embolism. If a patient is giving a features of deep venous thrombosis, or patient is having a pelvic surgeries like total knee replacement surgery, total hip replacement surgery, okay, so what are you suspecting? Pulmonary embolism. Right? If there is given that a patient is having a fracture of a long bones, femur, okay, what are you suspecting? Fat embolism, है ना? So hint, deep sea divers, air embolism, है ना? So all these features you go with a particular embolism. Now pulmonary embolism, fat and all other embolism you might have studied very nicely from the medicine point of view, but let's discuss amniotic fluid embolism. Now what exactly happens in this amniotic fluid embolism, my dear students? Now the contents of this amniotic fluid, they are entering into the maternal circulation. Now if you look out here, amniotic fluid is entering into the bloodstream, and when these amniotic fluid and its contents, they are entering into the bloodstream, they are going into the maternal circulation, okay, and they further lead to DIC, okay, which can cause amniotic fluid embolism. So what is amniotic fluid embolism in normal words? Sir, it is a intravascular invasion. It is an intravascular invasion of maternal circulation. Of maternal circulation. The intravascular invasion of the maternal circulation. And what is the reason of this invasion? The reason is amniotic fluid. So intravascular invasion of maternal circulation by amniotic fluid, and its contents leading to DIC. This is defined as amniotic fluid embolism. Now this amniotic fluid embolism, my dear students, it has two phases, first phase and second phase. It has two phases, first phase and second phase. When I talk about the first phase, there is cardiorespiratory failure. क्या होता है इसमें? Cardio plus respiratory failure. There is cardio plus respiratory failure. Okay, now when I talk about this classical triad, cardio plus respiratory failure, from the cardio point of view, patient is having hypotension, or respiratory failure say there is a hypoxia, and this is defined as the first phase of amniotic fluid embolism. Okay, and in the second phase, I've already discussed that there is a coagulopathy, so patient is having DIC. So remember the classical triad for the diagnosis. We have a classical triad, and this classical triad for amniotic fluid embolism, we have hypotension, we have hypoxia, and we have coagulopathy, and we have coagulopathy. Is that clear? Is that clear? So hypoxia, hypotension and coagulopathy, these are classical triads for amniotic fluid embolism. Clear to everyone? Yes. So intravascular invasion of the maternal circulation by amniotic fluid and its contents, which is leading to the DIC. It's an amniotic fluid embolism. So patient will come with the three features. Even they can mention the blood pressure was 90/60, the breathlessness was present, the saturation was 80. So with the given parameters, you can also suspect that there is a case having hypotension, hypoxia and coagulopathy. Okay, that is all about amniotic fluid embolism. So it's all about the part 1. Okay, so let's have a quick recap whatever we have studied. We discussed an ectopic pregnancy, we discussed the types of pelvis, we discussed in chapter abortion, PPH. Okay, we discussed the amniotic fluid embolism, we discussed about the ovarian tumors. Okay, we have discussed about the diagnosis of pregnancy signs. Okay, we also discussed about Asherman syndrome. Okay, so let's have a quick recap of whatever we have studied and conclude this session of the day. Okay, chale from the beginning only, guys. We discussed first about an ectopic pregnancy. What is ectopic pregnancy? It's a pregnancy which is outside the uterus. Okay, the most common site is going to be fallopian tube. Okay, and most common site in the fallopian tube is going to be ampulla, followed by isthmus, infundibulum and interstitium. Okay, now this ectopic pregnancy can be present in the cervix, abdomen and ovaries as well. Okay, now followed by that, the most common risk factor is the patient having a previous ectopic pregnancy, but the most common cause for this is going to be pelvic inflammatory disease. Okay, after that, the classical presentation of a patient with amenorrhea, pain in abdomen and bleeding per vaginal. Okay, and if a patient is having a ruptured ectopic pregnancy, due to the hemiperitoneum, there can be a referred pain to the shoulder. Along with that, there will be syncopal attacks due to the hypovolemia, decreased cardiac output. Is that clear? And then the hemorrhagic discoloration of the skin around the umbilicus, the bruising, it's called as a Cullen sign due to the hemiperitoneum, and on the flanks it's called as Gray Turner sign. These two signs are also seen in the case of a pancreatitis, but yes, other signs will define the diagnosis as well, like Fox and Bryant in case of a pancreatitis. Followed by that, we have on the per abdominal examination, we have abdominal tenderness over there. Okay, and then cervical motion tenderness will be there as well. Okay, in ruptured ectopic pregnancy, vitals are not stable due to the blood loss. Okay, and the shoulder tip pain sign is called as Danforth sign. We go for the complications of monochorionic twins. I will take in the part 2. Okay, I will take that in the part 2. Is that clear? Poly-Oli sequence, है ना? Twin transfusion syndrome, polycythemia anemia sequence, Khalid, I will take that in next part. Okay, followed by that, ruptured ectopic pregnancy. Okay, as discussed, unruptured, you have to see either the medical management or the surgical management based upon the beta HCG levels and the size of an ectopic. We have what? Medical management and surgical. If less than 5 centimeters, 4 centimeters, we go with the medical management. More than 4 centimeters, we go with the surgical management. Less than 5,000 international units of beta HCG, you go with the medical management. More than that, we go with the surgical management. Remember, there is only one management for the ruptured ectopic pregnancy, that is total salpingectomy. Vitals are stable, go with the laparoscopy plus laparotomy based upon that. But if vitals are not stable, you go only with the laparotomy salpingectomy, because laparoscopy will further decrease more cardiac output and further patient can go into the shock, serious symptoms. Followed by that, we have criteria. For cervical, we have Rubin's. For ovarian, we have Spiegelberg's. Abdominal, we have Studiford, and Caesarean scar, we have Gordon's criteria. Followed by that, we discussed about the type of the pelvis. Remember, fast. First one is gynecoid, occipito-anterior, rounded, and the most common one. Second one was anthropoid, oval-shaped, occipito-posterior position, and the face to pubis delivery. Third one was the android, having a triangle-shaped or the heart-shaped pelvis, having a deep transverse arrest. Fourth one was a platyploid, transversally oval, associated with the face presentation. Followed by that, we discussed about the teratogenic effects of the drugs. We discussed about the anti-epileptic drugs, fetal head and twine syndrome, ACE inhibitors, fetal renal hyperplasia, alcohol with the fetal alcohol syndrome, lithium with an Epstein anomaly, endomethacin with a premature closure of ductal arteriosus, and metamizole with the aplasia cutis, warfarin with the warfarin embryopathy, thalidomide with phocomelia, methotrexate with craniosynostosis, paroxetine pulmonary hypertension, erythromycin CHPS, and mifepristone with the Mobius syndrome. Remember the abortion, my dear students, the first trimester cause is chromosomal, second trimester via anatomical cause. In anatomical cause, I have discussed the septate, bicornuate, and incompetent os. Septate is the most common Müllerian defect. The management is going to be hysteroscopic resection. Is that clear? Second is the bicornuate uterus. The management is going to be Stressman metroplasty, because there are two horns due to the incomplete fusion of the Müllerian duct, and those two horns you have to unify them. Is that clear? That is called as unification surgery. Third is incompetent os. There is a short cervix less than 2.5 centimeter or less than 25 mm, which is also called as cervical insufficiency. Treatment, you have to apply the cerclage at 12 weeks and remove the cerclage at 37 weeks. The most common cerclage for use is gonna be the McDonald's cerclage. Above that is Shirodkar, above that is transabdominal cerclage. Is that clear? Then recurrent pregnancy loss we have discussed in the first trimester. The Aplas syndrome is the most common cause. Okay, Aplas syndrome is acquired thrombophilia, in which we have 3 antibodies: anti-beta-2 glycoprotein, anti-cardiolipin, and we have lupus anticoagulant. Okay, what will be the treatment? Give low molecular weight heparin plus aspirin. If we talk about inherited thrombophilias, we have protein C and S deficiency, we have prothrombin gene defect or mutation, or we have the factor V Leiden mutation. Followed by that, we discuss about the presentation of abortion depending upon the os and fundal height. If the fundal height is corresponding to the period of gestation and os is close, you go with the threatened abortion. Treatment as bed rest plus progesterone. If a patient is having a fundal height or height of the uterus less than the period of gestation or same with products hanging or bulging, it's going to be inevitable abortion with the os open. If the same scenario with a history of expulsion is given, you go with an incomplete abortion. If uterus is empty, os is closed, you go with a complete abortion. And if there are no warning signs and symptoms, there is a crumpled sac without a cardiac activity, is called as missed abortion. Is that clear? And without an embryo, it's an anembryonic abortion or the blighted ovum. Okay? Followed by that, we discuss also septic one associated with fever and infection like features. Okay? And followed by that, we also discuss that in case of a septic abortion, the size of the uterus will be larger or variable. Is that clear? Followed by that, we discuss about the parameters for estimation of the fetal age. The first parameter in the first trimester will be crown rump length, second will be biparietal diameter, and third will be femur length. Overall best, if they ask, mark crown rump length. Question will be like this, that the lady is not sure about her dates, you cannot go for EDD. What will be the best one? CRL. Is that clear? Followed by that, if the fundal height by 12 weeks, pubic symphysis, 20 lower border of umbilicus, 24 upper border of umbilicus, 36 cephus sternum. Okay, triple test, you have 3 components: beta ICG, AFP, and unconjugated estriol, UE3. They can mark which of the following is not. UE2 लिख सकते हैं, so make sure it is 3. Triol, okay, not diol. Quadruple test, you add inhibin A, not inhibin B. These are the 2 catch points, the question that they can ask. Okay, now Nagli's formula, it's only applicable for the normal cycle, okay, which is having a 28-day cycle. If extra days, 28 के बजाय 30-day cycle हुआ है, so you do 9 months plus 7 days plus 2 days. If it is less than 28 days, you subtract the days accordingly. Formula is 9 months plus 7 days. Okay, followed by that, we discuss about PPH. 40, stone, trauma tissue, and thrombin deficiency. Most common cause of primary is going to be tone, atonic uterus. Most common cause of a secondary PPH is going to be tissues. Okay, followed by that, we discuss that secondary PPH is something which occurs after 24 hours of the delivery. Okay, now prophylactic drug, as per the AMDSL, we start with the uterotonic agent oxytocin. How much you are giving? 5 to 10 units once after the delivery of the shoulders. But if the patient is having a case of a PPH, now you start with a drug oxytocin, 10 to 20 international units and 500 ml of NS. You will not give this drug in a bolus form because this will cause a sudden hypotension or the cardiac arrest. Okay. Followed by that, the second drug you are giving is a methyl ergometrine intramuscular, and the peak action in the 90 seconds. This drug is contraindicated in hypertension, Rh negative pregnancy, heart disease like RHD, okay, and before the delivery of the second twin. Misoprostol, we can give prostaglandin E1, 1000 micrograms. We can give carbopros, which is PGF2 alpha, 0.25 mg, maximum 2 mg you can be given. Tranexam or fresh frozen plasma if there is a thrombin deficiency. If the medical management is failed, we go the mechanical compression with Buckley's balloons, Foley's catheter, Sangestican tube and condoms. Okay, remove the Buckley's balloons once the bleeding is stopped after 12 hours. Compression sutures we can use. Compression sutures we can use like Bilin sutures, Heyman Coast square, or one more we have gun shell sutures. We have gun shell sutures. Okay, these are the compression sutures that we use. Anteriorly and posteriorly we suture the uterus so that they can meet at one point. Okay, that is classical Bilin suture. If multiple times अगर image में दिया हुआ है, that is a type of a Heyman suture. अगर squares में suture दिया हुआ है over the uterus, that is a co-square suture. Okay, and followed by that, even after the compression sutures, if the bleeding is not stopped, you go with the artery ligation, and the order of the artery ligation should be uterine, followed by ovarian, followed by internal iliac artery. Which branch of internal iliac artery? So I'm going with the anterior branch of internal iliac artery. If a examiner is asking the question that after the postpartum hemorrhage, the devascularization of the arteries were done, and patient is now complaining of a numbness in the lower limb, which of the following artery has been misidentified by the surgeon or the doctor? Your answer is going to be among these three. If they generally ask posterior internal iliac artery, if they give the branch, you have to remember superior gluteal, iliolumbar and lateral sacral. Okay, after that, if the bleeding is still not stopped, you go with the subtotal hysterectomy or the total hysterectomy. Subtotal में आप बस uterus को निकाल रहे हो, but in total abdominal hysterectomy you take out uterus plus cervix. Followed by that, I discuss that patient after the delivery goes immediately into the shock. Your most probable diagnosis with the fundus depression with the excessive bleeding is going to be uterine inversion. Now, what exactly is this uterine inversion? So, it's prolapse of the fundus of the uterus into the uterine cavity. So, what is the most common cause? The most common cause over here is going to be mismanaged third stage of labor or badly adherent placenta or sudden contraction or uterine atony. In badly adherent placenta, I've discussed that there is a absence of a neta bush layer due to which this placenta is invading or attached to the myometrium called as accreta, invading the myometrium called as increta, or going to the pelvic structures like bladder called as parcreta. Okay, and these adherent placentas can be the cause of a uterine inversion because once this placenta is invading the myometrium and pelvic structures, it will be difficult to deliver the placenta. That's why along with the placenta, uterus is coming down as well. So upside down, that is a uterine inversion. Patient first goes into the neurogenic shock followed by the hemorrhagic shock, but the most common cause of death, if the MCQ will be asked, hemorrhagic shock. The findings, there is a cup-like depression due to the uterus into the vagina, and on per vaginal examination there is mass in the vagina. This mass in vagina is called as Halban sign, है ना? चलो. Followed by that, management, resuscitation, call for help, try to push the uterus manually. This is called as Johnson's maneuver. The part which will come down the first will go into the last. Then you relax the uterus with the drugs, terbutaline and nitroglycerin, and then followed by that, give oxytocin and methogen so the bleeding will be stopped. If failed, Huntington and Haltian procedure. Now, if a patient is having a pseudomyxoma peritoniana, it's associated with the mucinous cystadenoma. Okay. Now, ovarian tumors, serous cystadenoma with samoma bodies. Mucinous में क्या होगा? Pseudomyxoma peritoniana. Brenner में we have pseudo-Meigs syndrome. Okay, with pleural effusion and ascites. Meigs में fibroma ovary, pleural effusion and ascites. Teratoma, all three layers are present. Ecto, endo and meso. And this is the most common tumor associated with the torsion and pregnancy. Okay, this germinoma में LDH and increased PAP. Schiller dual bodies with AFP and alpha-1 antitrypsin is yolk sac tumor. Inhibin and colexinal bodies is granulosa cell tumor. And if the tumor is secondary to the ovaries from stomach or the breast cancer with a signature cell, that's classically Krupkenberg's tumor. Okay? Asherman syndrome we discussed. It's also called as uterine synecdoche. It's usually after post-curettage or myomectomy due to the over-scarring. There are additions within the uterine cavity, and this is called as Asherman syndrome. Okay, what will be the management? Hysteroscopic adhesiolysis. So whenever a Asherman syndrome question will be given, my dear students, they will mention the case of abortion or secondary postpartum hemorrhage. Curettage ka history diya hoga. Is that clear? Followed by that, we discussed about the beta HCG doubling time. Okay, if beta HCG doubles in 48 hours, this is a case of an intrauterine pregnancy. If it doubles in 5 to 7 days, it's a classical case of an ectopic pregnancy. And if the beta HCG falls by 50% in 48 hours, this is going to be the case of abortion. Now, double decidual sac on the USG, outer layer is decidua paritalis, inner is capsularis, and it indicates, this double decidual sac indicates intrauterine pregnancy. If this is absent, this is a case of an ectopic pregnancy. Okay. Followed by that, we also used to check serum progesterone levels, but that's outdated now. More than 25 nanograms per deciliter and less than 25, but now we don't check the progesterone levels. Followed by that, amniotic fluid embolism. What is exactly happening? There is an intravascular invasion of the amniotic fluid and its contents by the there is an intravascular invasion of the maternal circulation by amniotic fluid, which will lead to the DIC, so that the contents are entering into the bloodstream. That's why the embolus is formed and mother is having a first phase of cardiorespiratory failure, where the patient is complaining of hypotension and hypoxia, and then the second phase, there is disseminated intravascular coagulopathy. This is a classical case of amniotic fluid embolism. That is all about the part 1. I hope, guys, the session was interactive enough and it will be useful for your upcoming exams. Rest of the topics we'll try to cover up by tomorrow in the part 2, all the important topics. And do watch the video again, and if you have any doubts, reach me out in the Telegram. You can ask me the doubts, okay? About the PDF, I'll share in the Meduhub channel, okay? And tomorrow we'll discuss with the part 2, okay? And if you have any queries related to the studies or related to this session, okay, any doubts, anything, you guys can text only related to the studies. I'll be there to help you guys, okay? Followed by this part 2, we'll have a PSM 1 and PSM 2. We'll try to go with all the recent updates of the PSM as well, and followed by that we'll do the pediatrics on the 4th of July, okay? So till then, keep revising the session, all the 19 subject revision that is on the Meduhub channel and app. Do join, okay? Revise and try to join in the active participation, the live sessions, okay? So that actively recall you can done. Is that clear? Chalo. I hope session was good enough. Till then, take care, keep revising, keep studying, okay? If you have any doubts, reach out to me, okay? And I hope we'll be able to get this exam done once you will revise efficiently. Till then, take care. We got this. Thank you.